everybody should be on a low-dose GLP-1. I think if you look at that from joint health, huge data on it now. When people start talking about peptides as these sort of foreign molecules, you stay away from these. Most of the peptides that I'm cycling people through are endogenous, made by your own body, and they decline just like your hormones decline. Birth control pills are horrible. They're very high-dose estrogen. They blunt your own progesterone because they have progestins in them. So they're the perfect storm for injury. Cartilage doesn't heal. It doesn't have much vascular supply. So what we can do is start using Pentacin now to help increase blood flow to the area and to prevent the progressive osteoarthritis. But used in the patient who already has osteoarthritis, actually we're seeing 30% improvement in cartilage structure. We're actually seeing cartilage regrow in these people. Progesterone is the bone builder. Estrogen is a bone stabilizer. So if you really want to build more bone, you need progesterone and anabolics like testosterone. Is it harder to make muscle as you get older? Yes. Even if you're keeping estrogen levels, progesterone levels, testosterone levels, thyroid levels, peptide levels all up, it gets harder to build muscle as we age. Injuries are more catastrophic as you get older. 1 out of every 4 women who has a hip fracture will die. 50% of people will never get back to their same level of activity. So lots of times, if you're older and you have somebody who was living independently, it's their push for them no longer to be able to live independently. Your best utilization of protein is occurring in your 20s. By probably 35, you start being a little bit more aware. But it's really 50 where you're going to start seeing the downsides if you're not prioritizing protein.
Welcome back to the Longevity Optimization Podcast. Today, I am so excited about our guest. We have Dr. Elizabeth Yurth. She is the co-founder and chief medical officer of Boulder Longevity Institute and one of the rare physicians who has spent 30 years in orthopedic and sports medicine before going deeper, earning fellowships in anti-aging, regenerative and cellular medicine, including her most recent fellowship from the Seed Scientific Research and Performance Institute. Plus, over 500 hours in CME on longevity, epigenetics, peptides, bioidentical hormone therapy, and regenerative orthopedics. She trained at USC Keck School of Medicine, completed her residency at UC Irvine, and a Stanford affiliate fellowship in sports and spine medicine. Welcome to the show, Dr. Yurth.
Thank you, Kayla. I'm honestly feel very privileged to be here.
Oh, that's
in your amazing home.
Well, thank you so much. I've wanted you on the show for a long time. I've followed your work. I don't even know how long. Years at this point. So I really love you bring just such a special group of skill sets to the industry that I think is so incredible. And I really love because you walk the walk, right? I've seen you without this little shrug on and you're like ripped. So I love that. I love it when people also do what they preach to do,
Yeah, I think we all have to do that because I think that's how our kids are going to learn what to do, and and other generations are just watching that these behaviors actually work for us.
Yeah, I love that. Well, let's kind of go back. How did you get interested in this? What brought you to kind of the sports side of things, and then how did you land on longevity?
It's certainly. You don't see very many people going from orthopedics into longevity, right?
Yeah.
You see a lot of ER docs or internal medicine docs or endocrinologists.
Yeah.
So orthopedics is a pretty rare breed to get into this field. And, the reason is because in orthopedics, you're taught that the key is you have something, you basically stick a steroid in it or do surgery on it, and that's the answer to every joint problem. And after doing that for quite a number of years, I just started to realized it wasn't working. And I was very compelled by one of my old partners had this sign that one of his patients had crocheted for him. And it said, after 50, it's just patch, patch, patch. And I was like, yeah, that's kind of all we're doing. We're really just patching one thing. Another thing falls apart. We patch that. Eventually you try and replace something, but eventually everybody just keeps kind of falling apart. And I said, there's got to be something better than this. I'm not just patching somebody together. Nothing ever got back to where it was. People still felt like, they were somewhat debilitated after an injury. And so I started exploring nutritional medicine, hormonal medicine, exercise science, all those things that we could use in the practice to really help people heal. And I realized that I needed to learn more. So I went back and retrained with A4M, learned all about hormones, learned all about nutrients, and started implementing that into my orthopedic practice. Started saying, wow, okay, if you came to me with back pain, actually, let's look at what your hormones are doing. What nutrients are you missing? What are your vitamin D levels? And the problem with that is it took a lot of time. So a 10, 15-minute orthopedic appointment did not really give the room to counsel people about your hormones and your exercise. And so realizing that I couldn't do this in these 15-minute appointments, we opened Boulder Longevity Institute, which opened now 20 years ago.
Yeah.
So we're one of the longest running longevity clinics that's, successfully maintained its status for a long time. And I would do that at night. I would see the patients by day, and I would say, hey, if you really want to like get deeper into this, you can come see me over here. So I'd work all day doing orthopedics, and then I would go at night and do my Boulder Longevity Clinic. And it kind of it was very small at the time, and then it's grown into a very big practice now. What really pushed me out of orthopedics, because I really only left my clinic about now 6 years ago, and it really was the straw that broke the camel's back, was one of my younger partners came to me and he said, you know what? We don't want you doing this anymore. We don't practice medicine here. We practice orthopedics. And there's no place for you to be talking to people about hormones in an orthopedic practice. And I was like, wow, I don't belong here.
Yeah.
But it was hard to walk away from. I've been doing it 30 years. I was partial owner in a surgery center, partial owner in an MRI scan, so it was very lucrative, right? To say, okay, I'm giving all that up, and starting with this thing was really scary. But like most things in life, these things sort of push you to a next level, oftentimes being really hugely beneficial. You needed something to push you out, right? And you've been there too, right?
Yeah, absolutely.
You need something to make you take a step away, because you're fine, it's doing okay, everything's good, but it's not where you belong. Yeah. And so when I completely left there and opened with the longevity clinic full time, it just soared, and so never looked back.
I love that so much for you. Yeah. Yeah. It can be scary to like make a shift, but then once you do, it's so fulfilling, right? Like it's just so much more fulfilling.
Yeah, you hear that more often, right? Very rarely do you hear somebody say, oh, I really regret that decision.
Yeah.
It happens.
Yeah.
But in general, most people would say it was good that something forced me to jump.
Yeah. Well, good. I'm glad in hindsight that they did that, because obviously your patients now are just going to get such better care. Not saying that they weren't getting good care then, but I mean, this multifaceted approach, I mean, obviously it works better than the traditional approach, right?
Right. And we still do a lot of orthopedics. So we now do regenerative orthopedics, but we always combine it with whole person treatment. Yeah. Never just focused on, it's just your knee. It's not just your knee. There's always something systemic. So I still get to do orthopedics. I still get to do a lot of procedures, and I just am doing it in a way that is much better for the patients. Yeah. And we see tremendous outcomes.
Yeah, I love that. Well, I'm definitely excited to dive into some of the like regenerative stuff that you all are doing, and what you're saying works best. But I want to kind of start on exercise, because, I think there's a lot of rumors out there, or kind of like myths. The women's health space is like very convoluted. At least my Instagram feed is. There's some people saying you don't need to make any changes in perimenopause and menopause as it relates to protein intake, exercise, etc. And then there's people saying that you need to change absolutely everything. You have to downregulate on luteal phase, etc. I mean, I don't do any cycle syncing. I also don't have any period, like PMS symptoms. I have a period, no PMS symptoms. So I've always just trained pretty much the same.
Right.
I'll downregulate if like, my Oura ring data is horrible or something, or my HRV is super low. But I don't do downregulation automatically, because how are we going to hit longevity goals that way? So would love to hear your perspective, and how, if at all, you've changed your training through midlife, and what women really should do.
I think that you've got to hit somewhere in between there, because number one, if we start, trying to plan all of our training around our cycles, if you start making, these big dramatic changes in perimenopause, menopause, it gets very complicated, and probably that the small gains you make from that are superseded by how much you've complicated your life now. Yeah. I will say, if you have somebody who's a sort of high-level athlete, and you look at what happens through their cycle, there is a much higher rate of, for instance, ligament injuries in the preovulatory estrogen surge. So estrogen makes our ligaments much more lax. And women already have 2 to 3 times the rate of ACL injuries as men. So it's dramatically different for us. So if you're training in that preovulatory cycle and you're doing something really hardcore, that is your highest window of having an injury. So should we be sensible about that and maybe think, okay, maybe in this phase, this is not where I'm pushing my hardest on the ski slope. Maybe I back off, that run early, so before my muscles fatigue, where all the load isn't going to my ligaments. As somebody who has torn their ACLs 4 times, I can tell you it's not a fun thing to go through. Yeah. And so I think that there is ways we can look at preventing injury. I don't know that it makes that much difference in terms of saying, okay, this is your best muscle building time. I think that gets too complicated. If you want to pin it down, there's things you can do. But I do think looking at training injury prevention may be beneficial, because injuries are so catastrophic to your overall health, right?
Yeah.
if I look at what happens through, perimenopause, and as somebody now who's, in their 60s, how you've had to change training. I would like to say that I can train as, the same way I trained when I was younger. But there is the downside of injuries are harder to recover from as you get older, even with everything you and I do, right? We have access to HBOT and saunas and peptides and all those things. It gets harder to recover as you get older. Injuries are more catastrophic as you get older. So I don't do some of the things that are a little bit more likely to injure. I'm a huge skier and I love pounding bump skiing, but have I downsized that a bit? Yeah, I've downsized that a bit. Yeah. It makes me a little sad, but I do think for me, I have to, as you get older, you do still have to look at a little bit of the injury prevention. Now, is it harder to make muscle as you get older? Yes. Even if you're keeping estrogen levels, progesterone levels, testosterone levels, thyroid levels, peptide levels all up, it gets harder to build muscle as we age. And some of that we think is when you look at muscle energy currency, we look at mitochondrial function in muscle, that declines as we age, and that's a harder thing to repair. It's possible, but it's a harder thing to repair. So I do think you want to look at when you look at, for instance, I do mostly weight training. I do a lot of heavy weight training, but I've done a little bit more now, higher reps, a little bit lower weights. You still want to push heavy, you still want to lift heavy weights, but you probably want to think a little bit. Now I'm not going for my 1 rep max, and the key is you don't need to. You get the same benefit at 30% of your maximum load with a few more reps as doing 90% of your maximum load. The key is going to muscle fatigue. I just did a post about, somebody put a post on Instagram about Pilates and how stupid it was because Pilates did nothing for muscle. And that's actually bull. You can make Pilates do a lot for muscle. You just have to do it to the point of fatigue. So the key is muscle fatigue. So I do think changing training a little bit is probably sensible, more for the injury prevention level. Now, as far as how do you make muscle building better, I do think you need to focus more on protein, right?
Yeah.
And the key is, it's been well shown now that protein utilization gets harder as we get older. And so a younger person can actually utilize their protein stores better than I can. So I need more protein to get the same benefits. So, I have a 19-year-old son who's always trying to always trying to bulk. And so he's pounding food, he's pounding protein, but he can utilize his protein a lot better than I can. So the key is now I've got to always be protein focused. Now, to keep that in the calorie range, that's where, a majority of your calories have to come from protein. And I do think you need to get up into that, we always say 1 gram of protein per pound of body weight, maybe even sometimes looking up into like 1.2 grams of protein. Super hard to do. I mean, you and I are pretty tiny. That's even for me, that's still 125 grams of protein a day.
Yeah.
I don't know what you get a day of protein, but it's hard, right?
Yeah. Yeah. Somewhere around there. I was going to ask how you do that. I do supplement, like I'll do this, like yogurt bowl and then add in the collagen peptides, add in like whey protein. So yeah, I am doing some supplementation. Majority I'm trying to get from Whole Foods, but yeah.
Which is the best way to do it. But I think it becomes very difficult to get 125, 130 grams if you're somebody who's a little bit bigger, 150, 180 grams. I do think most of my patients, I end up having to add in some supplementation. Yeah. And collagen peptides are great because they're adding a little bit more protein, but also have huge benefits for joint health, which we could talk about later. But the key is, I do think, like for me, I make a protein shake. I leave it in my car while I'm at the gym, and I drink that on the way home from the gym. Now, there's not a lot of evidence that you have to protein load right after exercise. My generation, that was always, you have this 2-hour window to protein load. Bill Campbell's kind of disproven that with his work. Probably it doesn't really matter when you get that protein in. It matters that you get it in somewhere. Yeah. I still, for some reason, bias to trying to protein load a little bit after my exercise. So I'm usually trying to get 40 grams, right away. First thing, and I exercise at 5 a.m. So, first thing in the morning. And then I usually, encourage my patients. I love eggs as a protein source because they have so much other value.
Yeah.
The choline in eggs. Eggs are just sort of a superfood.
Yeah.
So I try and encourage them to get some from eggs, and then your, lean meats, fish and chicken.
I love that. I want to go back to the ACL tear thing because that's so interesting. So in the follicular phase, that's when you have this higher risk. Why do we think that it is in general that women are having more of these ACL tears? Is it the higher is it estrogen?
Well, that pre-ovulatory estrogen spike is that's when you see the most ACL tears occur, right? But our higher levels of estrogen, at any rate, will create that. Will create that. We have stretchier ligaments, so basically you take the joint a little bit farther than it should go, so it allows the joint, and then the ligament can't tolerate those forces. So there are other reasons for it. So the other thing that happens as we age, and even now you've seen in younger and younger ages, is this drop in progesterone. And we sort of neglect progesterone's importance, and it's actually critically important to joint health and to ligament health. So the other thing that happens is, like in perimenopause, or even in your 30s, right, where we start to see this estrogen dominance, where estrogen is just much higher than progesterone. We want this ratio really of a progesterone to estrogen, where progesterone to estrogen ratio in an ideal setting is like 100 to 1. And when that ratio switches, so even if my estrogen's not surging up higher, when that ratio starts switching, when I don't have this anti-inflammatory benefit of progesterone. Remember, there's progesterone receptors on joints, on ligaments, on tendons. So when I start losing that effect, that protective effect of the progesterone, even with normal estrogen levels, I'm increasing my risk of ligamentous trauma or tendon trauma, which is why you start seeing more Achilles tendon injuries and ruptures and things like that. Somebody playing pickleball. The pickleball has been my partner, who's one of my workout buddies, ex-partner from my orthopedic practice, is a foot and ankle surgeon, and he loves pickleball because it's been the bane, for Achilles tendon ruptures.
Goodness.
And a lot of women, and because you look at who's playing pickleball, right? It's these kind of women my age, or in their 40s, 50s, and they're now seeing it younger, but this estrogen dominance picture is still going to create that same dysfunction.
Is there, if you're doing like mobility work or stretching or things like that as a part of your warm-up, is that helpful at least?
Probably not that much, because, warming up is, if you have a ligament that's just over stretchy, right, is stretching it more ahead of time going to allow you to not rupture? Probably not. I am hyper flexible. I was a dancer. I am super flexible. And probably one of the reasons my ligaments tore more easily was because they are hypermobile. So does stretching really help? Now, does it loosen up the muscles a little bit? Yes. Does that make other injuries maybe a little bit less likely, like muscle strains? Yes. But I don't think you can prevent ligament injuries simply by stretching ahead of time.
Yeah.
It is where muscle strength will help, right? Because what limits the amount of force my ligament's going to have is that the muscles are going to kick in and protect it. So if I have weak hamstrings, remember, our hamstring kind of wraps around our knee. So it actually acts a little bit like an ACL. And so if my hamstring's nice and strong, I have less force onto my ligament. So certainly muscle strengthening is beneficial to that ligamentous health. But I don't really think, as much as I'm an advocate that yes, a little bit of warm-up is going to probably prevent you from straining your hamstring while you're running, I don't think it's going to really prevent you from getting an ACL tear.
Yeah. Okay. That's powerful. I also want to go, you mentioned like the difference between elite athletes training and, really taking into consideration this injury prevention. Where do you think, if it's obviously this is going to be bio-individual for everyone, right? But I want to make it clear for everyone listening, most people are not training like athletes, right? They're actually probably not training enough. So where do you think that kind of like, obviously, if you're a professional athlete, that's a very clear line. But if a woman's listening to this and she's like, okay, maybe I need to downregulate a little bit in the follicular phase because of this injury, how would you help guide her to know whether or not that's relevant or not?
I think that's the phase where, so even if you're going to your F45 class, right? That maybe that's not the time when you're trying to do high box jumps. So little tiny modifications like that, right? Maybe I get out of doing side-to-side leaping motions during those periods of time. And I focus more on limited range of motion strength exercises during that window of time instead of doing my more plyometric type of exercises, where I'm more jumping, leaping, moving side to side, twisting, those kinds of things, because that's where you're going to injure yourself, right? Yeah. I would say more where it's going to fall into is, for most of our just people who are your average Joe athlete is when they look at their sports, what they're doing with their sports, where, that, like I said, that last run on the ski slope, maybe skip that last run. My muscles are fatigued, and, or maybe this is not the time when I'm going to decide, this 3-day window is not the time where I'm going to try and take my hardest mountain bike ride. So even if you're out there kind of being your average weekend warrior athlete, you can probably use this to some guidance to prevent injury. But I do think even in that training, think about doing more limited range of motion, muscle strengthening during those windows of time. You're not talking about a lot of time, where you just back off a little bit from doing more of the extreme plyometric type exercise.
Wonderful. And what is the 3-day window? It's right before ovulation?
Yeah,
is
so
that one
just
there?
Pre-ovulatory, sort of couple days, yeah.
Yeah, so women also need to be knowing if they're ovulating and tracking their cycle.
Right,
so
right.
There's that
Which
too.
some women that's really hard for to know, right?
Yeah.
If you're not, I mean, you can, an Oura ring can really help with those kinds of things. You can look at temperature changes and now we're looking at these companies like Mira who are doing ongoing hormone monitoring, which is sort of nice. I mean, it's really nice to kind of get a sense of what your cycles are doing.
Yeah, I'm excited for
especially women who have a Mirena IUD in, for instance, where there's going to be a little difference in their hormones. Remember, this is where birth control becomes a huge issue, right? Like, birth control pills are horrible.
Yeah.
They're very high dose estrogen.
Mm-hmm.
They blunt your own progesterone because they have progestins in them.
Yeah.
So they're the perfect storm for injury. And how many women are on birth control pills? But even like the Mirena IUD, which is a progestin IUD and arguably safer, even though it's a progestin, which is really a carcinogen, it's at least a small dose of progestin. And that still is blunting your progesterone. So lots of times women who have like a Mirena IUD, you want to have them on a little bit of progesterone to balance their estrogen a little bit. It's really the only, the safest, obviously, type of birth control is following your cycle, and but it doesn't work for everybody. So if so I certainly have a lot of women who, my next choice there is a copper IUD, so at least it's not hormonal IUD, but a lot of women hate that because it makes their periods heavier, things like that. So I certainly have a lot of women who are using birth control, and I if I can't talk them out of that, I have to work with them until we actually try and adjust the hormones around that to prevent the downsides of doing the birth control in terms of joint health and cancer health and everything else.
Yeah, I mean, so interesting, because I'm sure that the majority of people on birth control are not getting bioidentical progesterone added on there.
No.
Yeah, just
Not at all.
definitely not.
Right.
Probably
and the massive dose, remember the other downside too when you're on birth control pills is you have this massive estrogen load that raises sex hormone binding globulin. So now you bind all your testosterone off, right? So now you have very low free testosterone in these women who are on birth control pills because they make testosterone, but it's being bound by this high binding globulins. So now they have this perfect storm: high estrogen, low testosterone, low progesterone. So that's the worst case scenario for a tendon or ligament.
I wonder when we're gonna have updates too. The recommendations with birth control. It's just
they still hand it out with nobody talking to, I mean, I came from a generation where, I was on birth control for years, right? Birth control pills for years. I didn't know. Nobody told me that, right? I hadn't studied what I study now, but that's still happening where I don't think doctors understand the downsides and, and really the long-term damage that can occur with these.
Absolutely. Well, I mean, some shifts positive are happening, with new ways to diagnose endometriosis and maybe the ferritin levels changing. So maybe, people
we're definitely making progress. I mean, I really think we're making progress.
Slow.
There's more awareness. There's more awareness by the consumer, which will push the awareness also. But it's slow.
Yeah, totally. Going back to the phases and increasing your protein intake and that kind of set of changes in life, what age do you think, obviously again by individuality, but approximately that women might want to start aiming for that higher protein intake?
Definitely around 50, you really want to start pushing that protein level up. I would say, your best utilization of protein is occurring in your 20s. By 20s to early 30s, by about 32, sadly, it starts to go downhill. Our proteins, ability to synthesize proteins, utilize amino acids, starts dropping in that early 30s. Now, how much of that is hormonally related, or related to other things that we could potentially modify, is a little difficult to decide. So if I have somebody who's in their early 30s, but I've checked their hormones and they're perfect, are they still going to have the issues? it appears that even that may have issues, that probably has to do with more mitochondrial function, still declining at that age. Unfortunately, our prime is really 18 to 22. So I would say you 18 to 22, you can massively utilize your fuel sources and do really well. Then probably around 30, things start to decline. By probably 35, you start being a little bit more aware, 40, a little bit more aware, but it's really 50 where you're going to start seeing the downsides if you're not prioritizing protein. So really, by 50, people really need to be, and I'll probably push that even say in 45 now when I look at, unfortunately, mitochondrial dysfunction has gotten worse and worse since our COVID era. Everybody got knocked with the viruses that we're exposed to. Almost everybody's mitochondrial function got really knocked by COVID. Almost everybody. Even if you didn't get a vaccine, just from the virus itself.
Yeah. Okay, well, that's a great recommendation. Before we move on from like kind of the muscle section, have you amended your training in terms of like, are you still doing compound lifts? I mean, all of that stuff. And then from a bone health perspective, are you incorporating any like jumping or things of that nature? And what are your thoughts on weighted vests?
So I definitely do compound lift motions. I think they're really critical to overall health. They're probably the best way to sort of work on muscle. I've been fighting a shoulder injury, so I've had to modify those a bit, using a little bit more machines right now until I can get the shoulder better. So you have to kind of work around those things, what works for you. But I definitely think compound lifts are still really critically important. I still think that we have to work with what individual people can tolerate based on injury rates and things like that too. So like I said, I've learned a lot dealing with my own injuries. You can't push this program on everybody, or you're going to have somebody with injuries. So I want to enforce that while compound lifts are still probably the ideal for muscle building, you can do the same thing with a little bit more care and attention to what you're doing by using machines and doing other things. Because I don't want to discourage people who are like, because you see all these people saying, oh, you have to be doing, squat thrusts and deadlifts. And some people literally their backs can't tolerate, their shoulders can't tolerate, their knees can't tolerate. So we really have to be able to work with that and not sort of, I think it discourages people then from exercising at all when we start saying this is the way to exercise. I think you have to look, and I do think the data is very compelling that you don't need to be pushing the limits. So while that might be the fastest, easiest way, it's not the only way.
Yeah.
In terms of your weighted vest question, I have a lot of comments on that because I love weighted vests, but we've way gone overboard for them, particularly in my women.
Yeah.
People are doing really heavy weighted vests, and you don't need really heavy weighted vests. What's been shown, so people, women who are your size who are walking with a 30, 40 pound weighted vest, and there's no evidence that that's going to do any better for you than more of a 10 to 15 pound weighted vest. And your injury rates are going to be higher.
Interesting.
So I think we way overboard. I was just talking with a company called Omorpho at the Asprey conference, who does more of these kind of weighted vests you can just wear all day long. They're like 5 pounds, but even their weighted vests that are for exercise, in women they're 10, 12 pounds, in men they're 20 pounds. So I think we really have to downsize it. You don't need to go so heavy with weighted vests. That a smaller weight can go a really long way, but I do think it's a great way. Like I just bought one that I could just wear when I'm at my desk, walking on my treadmill at my desk, and it's 5 pounds. Just by adding that 5 pound weighted vest, but doing it for extended periods of time, I'm going to get huge benefits, right? So I do think that's, again, it's a fraction of where are we looking at. That's the sort of the pinnacle of how much benefit I can get without getting injured. And we've found that we've pushed the limits too high on weighted vests. So think a little bit less. You don't need an 80% of your body weight load. You need more of a 10%.
Yeah. And what are the main benefits? Are we getting bone building benefits from them? Are we getting muscle building benefits? Is it more just like fat burning?
It's certainly the bone building benefits when you look at axial loading. So just putting more load on a bone is really helpful to bone. It's why, lots of times bigger people, even if they have a little more fat on them, don't get nearly as much bone loss as my little tiny people, right? Yeah. So smaller people have just less load on their bone. So certainly osteoporosis risk is higher. So by getting more bone load, and especially axial bone load on our spine, on our hips, where most of the fractures occur, is benefited by a weighted vest. The muscle benefits if I'm climbing stairs in a weighted vest, I'm going to put more load onto my quads and hamstrings by climbing stairs in a weighted vest. If I'm just walking in a weighted vest, it probably has more to do with the ability to improve VO2 max a little bit better. So probably the weighted vest in that sense of just walking, like me walking on my treadmill with it, is probably not going to help my muscle building much, but it is going to help my cardiac fitness a little bit more to do that, right? But obviously if I'm jumping around in my weighted vest or climbing stairs in my weighted vest, it takes more muscle to do that. Yeah. I do like the bone loading for it. I do think it's a great way to load the spine and load the hips. And remember, we downplay so much what happens when you get a spine fracture or a hip fracture, and your likelihood of ever having a normal quality of life goes way down.
What are the rates again of like mortality if you get a hip fracture, I think, for a woman?
So a hip fracture in a woman has a 25% mortality. So, 1 out of every 4 women who has a hip fracture will die. 50% of people will never get back to their same level of activity. So lots of times, if you're older and you have somebody who was living independently, it's their push for them no longer to be able to live independently. So, when you look at that as a risk factor of death and disability, we're really underemphasizing the importance of it, right? We are really critically not attending to bone density in women. I have so many women in my practice who are in their 50s who have never had a DEXA scan, who have no idea what their bone density is, right? So that's a parameter we should be following and testing on people. Probably getting your first one as early as 35 to know what your bone density is, because you build bone only into your 20s. It's a downhill curve after that.
Yeah.
And remember, hormones start dropping in your 30s, so you start seeing this drop in progesterone. Progesterone is, people always give estrogen the credit for bone.
Yeah.
Progesterone is the bone builder. Estrogen is a bone stabilizer, right? So if you really want to build more bone, you need progesterone and anabolics like testosterone. And then estrogen stabilizes it from not losing more bone. But people give all the credit to estrogen. They don't look at progesterone very much, or even testosterone levels. And those are really the critical players in rebuilding bone. So if you look at somebody 35, for instance, where, their estrogen levels are still good, but the progesterone levels are starting to drop, their testosterone levels might be starting to drop, they're still at risk for bone loss. And that bone loss starting at 35, I need to address then, because by 50, I've already lost 15 years of bone. It's huge. When you look at, so T-scores, guys, look at a T-score on and that's what you want to look at on your DEXA scan, is the T-score. And you want that to be a positive number. It doesn't have to be super positive, positive 0.2, whatever, but you want it to be positive. Any negative number, negative 1.0, negative 1.8, take that. So negative 1.8 means you've lost 18% of your bone. That's actually not even considered osteoporotic, but you've lost 18% of your bone. It takes having lost 24% of your bone before anybody would even consider treating you with osteoporosis, right? Horrible. I mean, you have to have lost a quarter of your bone before anybody actually puts you into the category of osteoporosis. And so we need to be identifying these people earlier, and then addressing it earlier. Might that be with exercise, seeing what nutritional things they might be missing, or hormones? But we need to start addressing that. So I like to have my first, bone density study by 35, and then follow that on a yearly basis to see what's happening. Now, if you're great at 35, maybe I can wait a few years. But mostly I like people to get these on a yearly basis. The regular physicians aren't doing it. So that becomes where people, you can get a DEXA scan for $99 cash pay. It's nothing, right?
Yeah. Yeah, I agree. Yeah, I got one a few years ago. I think I range from, I get one actually every year, but I'm basically in the 0.6 to plus 0.6 to plus 1.4.
Yeah, so that's great. So that's like tremendous, right?
Yeah. I mean, but I've been very intentional.
But you're right, exactly.
About it,
your life you'd expect that, right?
Yeah.
But still, even you're a small person, so that puts you at a higher risk, and Caucasian, smaller, fair skin, all those put you at a little bit of a higher risk. So that's great.
Yeah, and even is the mark like 127 pounds or something, that like 127 and lower increases your risk? So I mean, I'm a few more pounds than that now, but I mean, that was like my standard weight. It was like 125 to 127. So
and remember that the downside. I mean, I came from a generation of I'd like to say we're getting out of that. I think we did kind of get out of this skinny is healthy, view for a while, and now
going back.
We're going back the other direction, right? Yeah. We're starting to see the super skinny people now. After all the GLP stuff, we're starting to see the super skinny back into style. But I came from a generation of that you wanted to be super skinny, and that's when the biggest bone density was occurring, right? Yeah. So I've lost a lot of ground just by not eating well, not being healthy in my 1820s, right?
Totally, yeah. back on the muscle really quick, what is like the minimum effective dose? Obviously, we know what the, recommendations are, 150 minutes of moderate exercise. And then how much is the general recommendation for exercise or strength training? But what would you recommend? And then what do you do? What's like the minimum dose? And let's say what you're doing for a woman in midlife.
So really it's been shown that 2 to 3 days a week of weight training and is adequate. Probably even 2 days a week, you can maintain and build muscle. Done consciously with good load bearing, going to muscle fatigue, you can train it 2 days a week and do full body parts. The difficult thing with that is when you're doing 2 days a week, you're really having to think about doing full body. Some people will separate, they'll do upper body, lower body. That might be a good way to do it. Because I want to do a little bit heavier stuff, I isolate things into body parts. So for instance, on Monday, I'm doing chest and triceps. On Tuesday, I'm doing legs. On Wednesday, I'm doing a back and biceps, right? Thursday's more my cardio day. And Friday, I do a little bit more full body HIIT training. So the key is you can go a little bit heavier on things if you're split training. So you're splitting body parts up. Right.
Yeah.
But I think realistically for most people, if you can really think about getting in and doing at least a leg day and an arm day 2 days a week, or even a full body 2 days a week, that's a little more time consuming.
Yeah.
To do, and you've got to hit every muscle group. Now, as far as how much time does that need? Well, that's where if you're lifting heavier, you need less time than if I'm doing 15 reps of something versus somebody who can do 6 reps of something because they're doing a heavier weight. Yeah. So if I can lift heavier, which that by splitting up body parts, you can actually lift heavier weights, right? So that minimizes your time in the gym.
Yeah.
So the key, don't think about, okay, this many minutes, it's really muscle load to failure and how much time that's taking you, which is going to be a lot less time if you're doing heavier weights. So as I've now been dealing with an injury, I'm doing a little bit more longer workouts and, because I have to do less weight and higher reps.
Yeah. Okay, great. So minimum 2 days for the strength training. Cardiovascular training, what does that look like? And then how much VO2 max training, if any?
Yeah, we're kind of all over the board on that, right? In terms of, you look at like the Peter Attia view on how much cardio taking versus the Dave Asprey view on, who.
Oh my gosh.
Thinks, he's like, you need none. I think VO2 max, low zone 2 training is really important. Mm-hmm. I think that you need to do zone 2 training probably about, in an ideal situation, 90 to 120 minutes a week. I basically do 2 days of zone 2 training, and it's about an hour each time. The other thing is to hit with the high intensity interval training, right?
Yeah.
And that's where the debate comes in, is do you need both this long endurance training and high intensity interval training? Because there's a lot of components in the exercise world that say you don't need both. That high intensity interval training will train VO2 max as efficiently as zone 2 training. I don't know where I stand on that. I do both. Mm-hmm. So I throw in 3 days a week of HIIT training along with my weight training. So I think that the key is probably if you do good high intensity interval training, like if you have a Caro bike, something like that, that you can hit that hard for 12 minutes. And if you do that, you're getting the same VO2 max benefit as 120 minutes their studies are pretty compelling that you can do that. So I do think you can swap out zone 2 for really good intensive HIIT training. Mm-hmm. It's hard to HIIT train like that, right? Yeah. It's very intense to HIIT train like that. I kind of enjoy my zone 2 where I'm just, climbing a mountain, or I'll get on the treadmill and just do hill intervals, on the treadmill. I kind of enjoy that sort of, that's where I sort of zone out.
Yeah. I'll show you before you leave. I have this treadmill set up in the garage. So I got the 40 incline treadmill. And then I have this like amazing desk set up on it. So I can actually do like 15 to 20 incline while doing a slow speed. So I actually can type and work. But then I'm getting into zone 2, which is cool. So with the ability to take a super high incline.
Yeah, 15 to 20 is hard even at a slow pace.
Yeah, exactly. Well, because you can't, I had like one of those walking pads and I'm like, I'm getting steps, but I'm not getting any like real metabolic benefits here with just this walking pad. So I'll show you.
Yeah, you walk in, it walks so slow. Yeah. I'm not sure I could do 15, 20 and type. I probably have to do like a like a 1.2 pace.
Well, actually, I'll tell you what the trick is. So I use this app called Whisper Flow, and you just dictate. It's like, but it's way better than the dictation. So it actually like understands what you say and it fixes
Got it.
things.
So you're not having to type.
So
Sorry, really.
I'm at my desk with the computer, but I'm replying to emails with the Whisper Flow. So yeah,
I just learned about Whisper Flow this weekend.
yeah. Oh yeah, it's great. So that's my current setup. And then I have a Carol bike too. So
Yeah.
I use that.
Yeah, the Carol bikes are great.
Yeah.
My husband has one. That's what he uses a lot of. It's a great, efficient workout. And their data is really pretty impressive.
Yeah. Yeah. I have had one for so many years, but I just started going back to it this week, like a EMS suit, like a catalyst suit. Have you ever used one? Have you?
I have tried one, yes. And I think they're amazing.
It's pretty intense.
It's right. You can do again, here's a way to make biohack your exercise, right? I can make my exercise more efficient.
Yeah.
It's a place where BFR bands too, blood flow restriction bands. I use a lot of BFR bands, especially in people dealing with injuries and things like that, right? Because you can now work out, like I can do body weight squats with BFR bands on my legs, and that's equivalent of if I was doing actually weighted squats.
Yeah.
So there's hacks that you can do to lower your risk of injury, still get a heavier weight load. So when I'm dealing with injuries myself or my patients, I have them buy BFR bands, which are so nice. Now you can just buy great ones now that you can just app on your phone, they self-adjust, and it's a really nice, easy way to train. And you can just do push-ups and squats and things like that in your living room and get a lot of benefit.
Yeah. Yeah. I love that. I'm going to do like a little trial with the catalyst suit. I mean, the only thing that's annoying is it takes a long time to get it ready.
Yeah. That's what I didn't like about it. I almost bought one and I thought, the whole just getting it wet and doing is a hassle. I need them to make it better.
Yeah. I mean, it would be great if you just like tossed it on. Right. Then it would be amazing. But I am going to try to just see what happens with like slightly lower time commitment. And yeah, we'll see.
Yeah, I think we can biohack exercise a lot. I'm not sure we can biohack exercise to the point of like what Dave Asprey says of 20 minutes a day, but I do think we can, or 20 minutes a week is what he says. I don't think we can biohack it to that, but I think we can biohack it to be as efficient. To me, a little bit of exercise is the mental well-being of it, right? That being at the gym for an hour, to me, is my time where I can't think about anything else because I'm thinking about what I'm doing. Yeah. So there is that piece to me that there's more to exercise than just the muscle benefits and the cardio benefits. There's that sort of mental benefit. Yeah. There's also the piece of, the big thing about exercise that really is so important is when you're moving a muscle, you're creating what are called myokines. And myokines are basically chemical messengers that circulate all over your body and do really good things. So every time I'm contracting a muscle, it's helping my bones. It's helping my brain. Mm-hmm. So that's why, just repetitive contractions of a muscle are so important, and why, maybe if we get those down too small, we're not doing enough of that, you don't get the same benefit. It's really not like the time.
Yeah, great point. I just made a tweet the other day. I was like, who else is thinking about their myokine release while they're working out? Yeah. Because I'm like, yes, getting all the benefits.
Right. It's cool. I mean, think of that. Every time I move my muscle, right, I'm producing all these things that are going to help my brain, increasing brain-derived neurotropic factor in my brain, increasing growth factor. Absolutely critical to bone, right? So if you have somebody who's sedentary, you can do everything, get their hormones optimized. If they're not moving their muscles, the muscles are so critical to bone. So anybody who's sarcopenic or has muscle loss is going to lose bone, right?
Yeah.
There's a feedback mechanism. There's also bone feedback to muscle. So
yeah, absolutely. Okay, great. Well, I think we covered things to do. I agree on the VO2 max training and the, and I see that too. Like I track on Oura Ring a lot, like the cardiovascular age.
Yeah.
And I see when I do more VO2 max training, it increases in a positive way, decreases my cardiovascular.
So how much VO2 max are you doing?
Just once a week. So I'm doing a Norwegian 4x4 on the weekend. Yeah. I put it on the weekend, so I have a little bit less stress then too, because, as a woman, I think there's validity to compounding stressors, right? I think our hormones are more sensitive to stress and the HPA axis than our male counterparts possibly. So I do my VO2 max training on a weekend. So I have less stress on the weekend, and so I can hit that harder. But yeah, I really love that. Okay, I want to talk about joint health now. I know we've kind of like threaded it through the conversation, but I don't think that we have like a protocol basically. Like when do women start thinking about joint health? What works? What doesn't? We've heard about collagen, then collagen doesn't work. It's like all over the board. Peptide. Actually, before we move on to joint, I was thinking about doing a block of peptides, but let's talk about each peptides as they relate to the section we're on. So exercise, peptide world, peptides are now incredibly popular. It's crazy. I mean, you've been doing peptides longer than me, but I've been doing them like for 10 years and it's probably 8, but now they're just everywhere and everyone's obsessed with them. And they're taking peptides that like aren't prescribed by their doctor, bought off some random website that has no checking on it. But what peptides for exercise do you like, and which ones would you stay clear of?
So the peptides that are, when you look at specific exercise-related peptides, I kind of, the key to almost all health falls into the same things. And it's, increasing blood flow, it's improving our ability to repair, and it's preserving our mitochondria. And if we put mitochondrial preservation at the top of that tier, because in my mind, mitochondrial dysfunction is at the root of every single disease, including joint disease, including osteoarthritis, including brain disease, cancer. It's all mitochondrial. So when you look at exercise, why is our exercise decline and what makes it more efficient? It's healthier mitochondria. It's better mitochondria, right? So we have to look at the mitochondrial peptides there. But I'm going to take them out of that realm of they're going to be beneficial in my mind for every disease we talk about, including osteoporosis, because all things come down to mitochondrial function. So if I look at mitochondrial efficiency to sort of what we consider an exercise mimetic peptide, it's going to be MADA-C. The problem with MADA-C, think about MADA-C as revving the engine up. Like you press on the gas, it makes everything go faster. So it really is considered exercise in a bottle. And it can make your exercise substantially more easier to do, compound the benefits of it. But what if I have a really unhealthy mitochondria?
Yeah.
What if my mitochondria is structurally not sound and I try and rev up the engine? So think about this as I have this really old car which has a trashed out engine, and I'm trying to put it on the race course. It's going to die. So that's a big problem I see is there's, in somebody like you who's young and really fit and healthy, you can just rev up the engine. You're fine, right? And somebody like me who's in their 60s who has mitochondrial dysfunction, or my long COVIDers, or my people who have been sick, or my people who have metabolic disease, if you try and rev up the engine with one of the more exercise mimetic peptides like MADA-C, you're going to run into problems. You're going to just create more reactive oxygen species. It's like you're trying to spin out energy and you really can't. So we have to go back to most people need to repair the mitochondria first. So we have to use mitochondrial repair peptides like SS31, which is known as a lamprotide, to repair the inner cell of the membrane. So the inner part of your membrane, guys, is made up of something called cardiolipin, and it's where all the little cytochromes that pass energy, pass electrons through this chain, there's 5 complexes. As you're passing these electrons through, you get these protons that collect inside the inner membrane, and that's what drives this what's called proton motive force that makes energy. Well, when we get damage to the mitochondria, which happens to everybody as they age, but more substantially in somebody who's been under a lot of stress, or been ill, or overworked, or training too hard, the inner membrane of the mitochondria falls apart. So now these little complexes that are passing electrons through can't form this proton motive force. So what if I'm throwing MADA-C and I'm trying to get them to do that? It's not going to work. So what SS31 does is it repairs the cardiolipin. It repairs that inner cell membrane. So now I've got a structurally sound mitochondria. Now I can rev it up. I've polished my engine. Now I can put my foot on the gas. So that's where the mistake lies in trying to treat mitochondrial dysfunction or energy in people. And we see this a lot where these peptides have come out and people are all kind of pulling them and going, oh, this is the greatest thing since baked, sliced bread for improving exercise. Yeah, in the right person. And that's where the problem lies in the lots of times it's the wrong person. Like if I have somebody who has been ill, who's overstressed, who's overworked, who's overtrained, and they're trying to do that, they're going to create more harm than good.
Yeah. Wow. Do you do any testing on your patients to determine where they're at, like organic acid testing or like any of these mitochondrial tests?
So we do organic acid testing, which can be really beneficial to try and figure out, just looking at pyruvate and lactates and things like that. There's some simple things you can look at just in basic labs. Since not everybody's going to afford or have a doctor who's going to order an oats test, an organic acid test. There's some really simple things you can look at in your basic labs, like a uric acid level. Uric acid gets a lot of blame because, yes, high uric acid level is bad. But think of high uric acid as an over-energy state, right? And high uric acid creates all sorts of problems. Well, low uric acid is equally as bad. It's a low energy state. So low uric acid is sort of a sign that your mitochondria are not working well when you see a low uric acid. it's a sign of low ATP production, a low energy state. So are very low triglycerides. So all these things that docs are like, oh, great, you've got low uric acid, you've got low triglycerides. If you have a triglyceride level that's less than 65, you're actually in probably an energy deficient state. Your mitochondria are not functioning as well. So triglycerides should be maintained really well if you've added really good peroxisomal mitochondrial function. And if it's not, so those are two, like, they're on every test almost, right?
Yeah.
So two really simple things that you can monitor very easily.
Yeah.
And then you can look at organic acid tests more in now trying to get next level of information. But we need easy information that we can follow closely very quickly. And those are two things I can look at very easily to look at. The mitochondrial tests, I think, can be beneficial. I think they're not quite great they're great for my people who have more severe mitochondrial disease, right? It's really helpful to me when I have somebody who has more severe mitochondrial dysfunction and they're not responding, and I'm trying to figure out all these little nuances. They're great. They were designed, when you look at them, they were really designed for more genetic mitochondrial disorders. So when you have somebody who has more subtle mitochondrial dysfunction, right? And, and you can say, okay, can I isolate down this to complex 2? I'm not sure the technology fits yet for that. I think the studies have all been done, and these tests were developed for the more sick population, for the people who have these genetic disorders. And then we tried to translate them down into the healthy individuals because we're all getting into, let's all do mitochondrial testing. And I'm not sure that we have the data to correlate what these tests show in a healthy individual when there's mild mitochondrial dysfunction. I think that maybe we'll get there, but I'm not sure they're worth the money at this point. So I usually stage 2, look at some basic labs, look at your energy levels. So look symptomatically, right? You have low energy, you fatigue fast, you can't walk upstairs, you have mitochondrial dysfunction. I don't need a bunch of tests to show it, right?
Yeah.
And then look at some basic lab function, and then go to your oats testing. And then if you really want to compound it, get some mitochondrial testing. But I don't know that we're ready for prime time on what is a perfect mitochondrial testing to say, like somebody like you who's perfect, what is perfect for you? We really don't know that.
Yeah. No, I would agree with that hierarchy too. I think if you want to look at it because it's interesting or you want to do it, go for it. But yeah, I think I just learned this about these 2 markers. That's great. That is so accessible for most people.
Right, exactly.
So
super easy. It's on every test. It's $6.
Yeah, I love that. In terms of mitochondrial, we'll finish on the peptides. I have so many questions to ask you. So with most of your people, do you see doing SS31 first? Because most people just have mitochondrial dysfunction.
So when I treat people, almost always I'm treating them with a course of SS31 first. The problem with SS31 or Lamprotide is that it's expensive.
Yeah.
And honestly, truly, you need a high dose to really get people better. But you can do a high dose for a very short period of time, even a few weeks sometimes in people, just to get this kind of mitochondrial repair. If I think in a perfect world, for my patients just trying to stay young, they should be doing SS31 because we all will get mitochondrial demise, right?
Yeah.
And so everybody should be doing a couple courses of repair throughout the year. So maybe a couple courses. In a perfect world, you want to do 20 milligrams, even twice a day of SS31, and for like a 4 to 6 week period. That's pretty outrageously expensive for most people. But even if you can get somebody to do that for a couple of weeks, especially somebody who is healthy, I think that can be really helpful to do some mitochondrial repair. And then we can go to the SS31s, things like that. And even a lot of supplements that are beneficial there, like Urolithin A.
Yeah. Yeah, that's part of my stack. I mean, in general, would you say that the playbook for better mitochondria is, for me, it looks like morning sun exposure in general. I do morning sun, we take a walk around the neighborhood. Then I also do midday sun too. I wear a sun hat so I don't get my facial skin, but I do midday sun and do that for 20 or so minutes.
Right.
Consistent sleep schedule, obviously high quality nutrition, try to keep stress as low as possible, social connection. And then I would probably throw in there red light therapy. I think the VO2 max training for, the mitochondrial biogenesis and mitophagy, and then the zone 2. Is that kind of like a playbook for mitochondrial
Yeah, definitely agree.
health?
I think, mitochondrial biogenesis, and we throw that word around, and you have to remember we actually don't make new mitochondria. The only thing that happens is we get rid of bad mitochondria. That's why autophagy or mitophagy is so critically important. And then we recycle those parts and we get our healthy mitochondria divide. They do what's called fission and they make a second mitochondria. So it's not like our body's spitting out new mitochondria like it might spit out a new red blood cell, right?
Yeah.
So there's a little misnomer there, and that we get fusion or fission where we actually destroy a mitochondria or we split apart, which is fission. Now we have two healthy mitochondria. If I have a really unhealthy mitochondria, I can't do fission. I can't make new mitochondria. This mitochondria has to be, number one, healthy, and number two, stressed enough to say, oh, I need help. And then it powers up, and when it has enough power, it divides. And now you've got two healthy mitochondria. So that's really what's happening with mitochondrial biogenesis, not so much making new mitochondria, but allowing healthy mitochondria to divide and make a second mitochondria. The key player there, why things like Urolithin A are so critical, is the mitophagy part. Because if I can't get rid of damaged mitochondria, then I actually can't allow the healthy mitochondria to multiply. And so, bar none, you have to do something that's encouraging mitophagy. And, because a lot of things you're doing when you're talking about, your circadian balancing and your sleep and those things, those are great. Mitophagy sleep is really critical there. But a lot of things like red light's probably more useful for sort of revving up, getting the fission piece. So I think that's where compounds like Urolithin A, which has been well documented, help mitophagy, and Spermidine.
Yeah.
So I think cycling Spermidine is a really, and again, we've now learned, we learned so much over time. Like, I loved Spermidine. I was like, but I'm not seeing great results with it. And now it looks like we were way underdosing it. Same thing's true with Urolithin A. The dose was 500 milligrams. Now we know it's a gram, really, to actually get benefit.
Interesting.
So the studies have kind of now said, oh, actually, maybe we need more. And Spermidine, we were saying 2 milligrams, 6 milligrams. Now we're saying 20 milligrams. So we need a higher dose Spermidine now to really see the benefits. So when we actually started looking at in humans, the outcomes we were seeing as we're using these things. Remember, one of the problems with a lot of supplements is we dose supplements at what's a safety level, right?
Yeah.
They have to dose it so that if you're a stupid person and takes 8 of them, you're not going to die, right? So it's not necessarily the dose that's on the bottle isn't necessarily the dose that's therapeutic for you.
Yeah. With the Spermidine, how are you cycling that? How long are you?
So what I like to do is I like to do the 20 milligram course, and I'll do that for a 6-week period, and then off for like 6 weeks and then on. So I like to just cycle that in 6-week cycles to get rid of, kind of clear house, sort of like take out the trash.
Yeah.
Right. And I think that's a really good thing. I think that is a really good mitophagy agent. Now, Urolithin A is a little bit more unique. It's probably best for mitophagy, but it also does now encourage a little mitochondrial biogenesis. So it's a player that I think I just stay on board all the time.
Yeah.
And its studies in muscle are very compelling, right? I mean, when you look at the studies in muscle building with Urolithin A, even in no change in training, there was significant improvement in quad strength, in muscle strength in elderly people. So it has definitely some benefit in mitochondrial health beyond just its mitophagy effect. So it's one I think most people should just stay on.
Yeah. What about the other one? Have you experimented with that at all? Mito-Q?
So Mito-Q, I think, is a really good, I think it's a great, once you've got a good, healthy mitochondria, I do think Mito-Q is actually really beneficial as well. It's a great one.
So would you, if you were just doing the supplements, if you couldn't do the peptides for mitochondrial health, would you do the Mito-Q after?
I would do Mito, I'd be doing, if I prioritize, it's going to be coenzyme Q10, but you need to have coenzyme Q10. This is where people really screw up, and a lot of doctors don't even know this. It has to have what's called geranyl in it, or GG. So you've got to look for a CoQ10 that has GG in it.
Do you have a brand that you like?
There's Designs for Health makes one. OHP Health makes one. So the key is that for coenzyme Q10 to work, it needs this other pathway feeding into it. If you don't have the GG in there, then we can't get the benefits of CoQ10. And nobody does this. But if you actually look at pathways, there's a few of us in the mitochondrial world who even know this. But if you look at the pathways, it becomes a really critical player. You'll get some benefits from coenzyme Q10, not nearly as much. It's why we don't see the outcomes with CoQ10 that we thought we would for mitochondrial health. It's because it's lacking the GG. So you really, guys, want to look for coenzyme Q10 with geranyl. So I think you need the coenzyme Q10 with geranyl. I would put PQQ on if you have enough money. Go to PQQ, but you don't need to have that one in the stack. I think it's great.
You'd add it with CoQ10 or in place of?
You could replace the CoQ10 with PQQ or I'm sorry, Mito-Q. not PQQ, not pyridoxyquinolone. So MitoQ, you could probably replace the CoQ10 because it gets into the inner mitochondrial membrane, right?
Is it MitoQ is a version of?
Yes.
Okay, yeah.
It's one that gets more absorbed. So I think you could probably substitute. It's more expensive typically, but you could probably substitute that for CoQ10. And I cycle the Spermidine. I would do Urolithin A ongoing. And the other add-on I would do is alpha-ketoglutarate. So alpha-ketoglutarate is really helpful for mitochondrial function and way underplayed and underutilized. And again, an underdosed supplement as well. It needs to be at least 2 grams. That stack is hugely great for mitochondrial health. You've addressed mitophagy. You've addressed the alpha-ketoglutarate combination will actually rev up the mitochondrial function, so it'll make the mitochondrial more active. And you've addressed mitochondrial biogenesis with your Urolithin A. So I think if you're hitting those pieces from a supplement perspective, you're going to go a long way in protecting mitochondria. Now, where, if you suffered a really bad illness, if you're really deconditioned, that's where you probably need something more to help you, like a peptide.
Yeah. Yeah.
But you can do a lot with those. I mean, you can. If you guys can't afford these, even in the sickest people, doing that combination is going to do a lot.
Yeah. My team recently told me that only 50% of you that actually watch this video are subscribers. If you watch this content and you enjoy it, I would really appreciate a quick subscribe. Take a second to do it now, because the more subscribers we get, the better the podcast, the better the video content can be. So would really appreciate that. Now back to the video. What are your thoughts on people buying all these peptides off the internet? I've had like 300 million companies approach me, obviously.
Yeah, I'm sure.
But I've said no to all of them because I've only personally ever taken peptides that have been prescribed by my doctor and then have been compounded at like an appropriate facility. So what are your thoughts? Are there any good resources, for these?
The studies have shown that most of the research grade peptides have what they say in them, meaning they do have enough of the actual peptide they're saying is it. What they also show is as much as 75% of them had higher levels of contaminants than would be acceptable to somebody like you or I. So when we look at the studies that have done on the research peptides, yes, they have what they say. You're gambling how much other toxins like arsenic, for instance, are in those, heavy metals particularly, right? Arsenic probably being one of the biggest ones. And the compounding pharmacies have to do a second layer of testing. They have to abide by much stricter standards about contaminants. So when you get your certificate analysis and it says, oh, we've met these guidelines from your research peptide company, their guidelines are just different from what an FDA-approved compounding pharmacy has to do, or 503B compounding pharmacy has to abide by. So they can't have the same level. People always argue to me, it's exactly the same thing. They are getting their substrate from the same places in China, which in lots of cases is true, with the secondary testing being that they have to go through a different level of purity testing to ever be able to sell it to you. So I think that, are you getting what, am I getting Mitoc in my peptide? Probably. Am I also getting a high load of toxins? Probably. So I guess it depends on how happy you feel taking a bunch of toxin load. For all of us who, to me, you're undoing the benefit of the peptide when you're taking in a bunch of arsenic or lead or mercury or things like that in them. So I think it's a bad way to go. I think that in fact, the risk can be super high. We've seen this. I've seen people have horrendous reactions.
Yeah, I've heard of it too.
Yeah, and so if my patients want to do that, I'm like, I have no say in it. I will not tell you how to dose it. I will not help you. I will not help you for a complication, right?
Yeah.
I'm offended a bit by doctors who are prescribing the research peptides. They're now kind of guised as what the pharmacies have done. These research companies have done is they now call it, instead of not for human use, they say for physician use only. Right. So what that does is it puts the onus of responsibility onto the physician. So instead of saying not for human use, they're saying, well, physicians can do whatever they want. So if a physician wants to use this, they can. So they say, so the physicians now are seeing this label on the bottle is for physician use only, saying, oh, that's fine, it's for physician use.
Yeah.
Well, if that peptide, you pull off the little label, it's still a research chemical. And if I had to stand up in court and had somebody who had a complication and somebody held up this little bottle and said, so you gave them this drug that said not for human use, Dr. Yurth? I wouldn't have a leg to stand on. So I think, you're rolling the dice by doing this both as a patient and as a physician prescribing them.
Yeah. I've actually heard some of the companies lie and say that they're like a, 503B. Is that yeah? And
what they do is they actually say we're an FDA approved facility. That means actually nothing. My office is an FDA approved facility because we have supplements in the office. We have to be an FDA approved facility because we sell supplements out of the office. So we have FDA approval, right? It took literally filling out paperwork to become an FDA approved facility. It doesn't mean anything. You need to be a regulated compounding pharmacy. Yeah. So that's the trick they're doing is we are an FDA approved facility. That means nothing.
Yeah. That is very complicated. Yeah. So, I mean, again, all right, guys, my recommendations from this whole time still stand. Get these from your doctor and do them per your doctor's.
There's a lot of art to doing something. I've been doing peptides for a long, long time. Probably, I started doing peptides 10 years ago when we all sat around a little table. This group was 10 of us sat around a little table and started to work with a compounding pharmacy to develop these. And, and there's so much art to it that you will waste a lot of money sometimes just because you did things in the wrong order, the wrong dosing, use them for the wrong purposes. So you can actually, save a lot of money by working with a physician who actually knows peptides. And that's sometimes not always so easy to find, but a physician who really knows and understands peptides.
Yeah. Yeah. I mean, I kind of feel like we're probably going to go a bit of the way of like what happened with functional medicine, where like everyone now does functional medicine. Right. But like the difference between someone knows, I would interview like 30 doctors to find one that understood root cause medicine and wasn't just like green pharmacy. We have a lab, we're going to put a supplement to each, range that's out of value.
Yeah, I would say, most functional medicine has now gone what we always said we hated about conventional medicine, right? Oh, it's just protocols and blah, blah. And that's what functional medicine has become now, right?
And that's what peptide, unfortunately, it's just going to be hard. It's really, it's hard. People always obviously ask me like, what physicians to see. And a lot of the physicians that I have in my podcast are either not taking patients anymore.
Right. That's the hard thing too.
So, or they are very
We've been doing it a long time or now, now I'm teaching, I'm doing other things.
Exactly.
Right?
So it's hard to find.
It's hard to find good physicians, right?
Yeah. I usually recommend still looking at IFM or A4M and then interviewing them and asking them hard questions.
Right.
So.
And lots of times, it's like in my practice, I still take patients, but on a limited basis. But I have providers who I have trained, who I oversee, right?
Yeah.
So even though somebody's seeing one of my other providers, they get me behind the scenes. Yeah. So that's the other thing to look for is, okay, well, even if that doctor isn't seeing patients, do they have people that they're overseeing in their office who are seeing patients, so you're still getting their kind of brain? So I think that's a way to go too, is to find a doctor who is a well-established doctor who's been doing this a long time, and if they're not taking new clients, say, hey, do you have somebody in your office that you oversee, that's doing this, and that can work really well.
Yeah. Love that. What are your thoughts? So I used these years ago, then forgot about them, and now they're resurfacing. Bio-Regulators. Are you using them? What are your thoughts on them? Can you explain?
So I very much poo-pooed Bio-Regulators for a long time.
Yeah.
So Bio-Regulators guys are very, very short chains of amino acids. You're talking about 2 or 3 amino acids. And they were developed by a Dr. Kavinson out of Russia. And he developed them actually for the Russian military. The Russian military came to him and said, hey, our Russian military is getting overly stressed, blah, blah, blah. They're all falling apart. And he developed these Bio-Regulators. And there's a lot of research on them from Kavinson's lab. It's all Russian research, right?
Did you see, by the way, it just came out, and I haven't even read it, but like Putin's longevity journey, it's like 26 million, 26 billion. Anyways, they're talking about how so much of this research has come from Russia because under Putin's reign, like he wants to live forever.
Was Putin's doctor, right?
Yeah, because he like wants to live forever.
Yeah.
So.
And so he would develop these things, and there was a lot of debate with Kavinson's death whether there was something more sinister involved in that. So there's a lot actually of Russian literature on that. We just don't have a lot of American literature, and a lot of it when you translate from the Russian literature, it's like, oh well, I don't know. But as I've learned more and used more Bio-Regulators, I am becoming more compelled by them. So basically, they're 2 or 3 chain amino acids. Usually, a peptide is going to be, it's anywhere from 2 to 50 amino acids. After that, it becomes a protein. But in that 2 to 3 range, what a Bio-Regulator can do is it actually inserts itself into your DNA. So they actually create a genomic change. So it's kind of an ongoing benefit. So you can actually do a Bio-Regulator series and get benefit for a period of time, for sometimes 3-6 months. So sometimes you don't have to do these series a couple times a year. And they insert themselves into the chain. So probably, if you look at GHK copper is a Bio-Regulator peptide. Epitalon. So these are peptides we use a lot in the peptide world, but they're actually actually bioregulators. So by inserting themselves in the genome, they actually can have a longer lasting benefit. They're very homeostatic. They're very safe, and less expensive. There's oral forms.
I was going to say they're mostly oral. Is that
So there's oral and injectable, right?
Okay.
And so some of them can be absorbed orally because they're small chains, like GHK copper, things like that can, some of those, but they tend to work better as injectables still. There's some sublingual versions coming out that are looking pretty beneficial as well. So we're keeping an eye on kind of those as well. But a company called Profound Health is the biggest sort of, it's a Canadian company, but Cavenson gave the rights to Bio-Regulators to Profound Health. So they are probably the most legitimate source for Bio-Regulators at this point. And, what you do with Bio-Regulator typically is you'll do like Thymogen. Thymogen is a bioregulator peptide for the thymus gland. Our peptide version would be Thymosin alpha-1. Thymosin alpha-1 restores the immune system. Thymogen is a bioregulator peptide that does the same thing. Is it as good as Thymosin alpha-1? No. But if I'm a healthy person just trying to maintain, can I get some benefit? I think so. I think the data from the Cavinson's labs, as you've researched it and as I've used these a little bit, I think there's benefit. So what you do typically is a course of these where you take them for 30 days and then you repeat that cycle maybe 4 times a year. Or another way of doing it is 30 days and then the first 5 days every month. So there's ones for like the thymus gland. There is Ventafort for blood vessels. There's Cartilax, which helps, joint regeneration. And I think, are they nearly as powerful as peptides? No. But do I think they have some benefit? Yes. And they are easier to obtain for a lot of people. And I think we're going to see those come a little bit more into the forefront in medicine too.
Yeah. Yeah. I mean, that's a great question. Actually, I guess I haven't seen that much about bioregulators, so I guess we'll still be ahead of the curve on that one.
Yeah. I think that, so the oral ones are very easy to get on Profound Health right now. The oral bioregulators, and again, I think some of the oral bioregulators will work, but not as well as some of the injectable ones like Thymogen. And I think that the sublingual versions, which are, there's a company now who's working on those that are looking pretty good, pretty compelling.
There's a doctor that's here in Austin who does like young plasma exchange and stuff like that, more cutting edge stuff. She does peptide protocols kind of like on this yearly basis, like addressing the hallmarks of aging, which I think is interesting because the thymus gland, from what I understand, is kind of like the ovaries, right? Isn't it like aging at an accelerated pace?
Well, really, the thymus gland is gone at puberty. It starts declining. Well,
Okay.
gone, but it starts. So your thymus gland is huge when you're a baby. It's training your whole immune system. Right, so it's giant gland in your chest. If you do an X-ray of a baby, they've got this mass in their chest, and that's your thymus gland. And it's educating all of your immune cells what to do. Attack this, don't attack this. At puberty, so it grows until puberty. At puberty, it starts shrinking. In your 30s, it's pretty small. By the time you're 40, 50, it's a little fatty nub. It's really not doing anything. So you are not making thymic peptides anymore. And there's 2 main thymic peptides.
By what age did you say? Like mid-30s?
Like mid-30s.
Oh, no, that's me.
Like mid-30s, really, you're very limited. By the time you're my age, you have no thymus gland.
Goodness.
So it's not really even, that it's you, and you can't restore it. It's not like you can, it's so just like I can't give you new ovaries, but I can give you what your ovaries were doing, right?
Yeah.
I can give you.
Are there protocols around HGH or something like that people are trying to restore? Is that a
There was
thing?
that whole protocol using growth hormone and DHEA and and to see if you could actually restore thymic function, and it didn't work. You can't restore You can't restore the thymus gland. Let me put it that way. Can you improve some of the hallmarks of aging that are related to immune function, thymic function with those? Yes. So there's tricks around this, right? But the very best thing to do is to replace the thymic peptides. It's where I get a little bit, when people start talking about peptides as these sort of foreign molecules that like, oh, these are, you stay away from these. Most of the peptides that I'm cycling people through the year are endogenous, made by your own body, right? And they decline just like your hormones decline.
Yeah.
So it's like saying, oh, I'm not going to give you estrogen, because that's some foreign particle. It's not. Neither is thymosin alpha-1 or thymosin beta-4 or BPC. Those are all endogenous, made by you.
Yeah.
So should I start replacing them when they decline? My feeling is yes, that's how I'm going to maintain health. So if thymosin alpha 1 is declining, by 40, I'm going to cycle it a few times a year, right? I'm going to give thymosin alpha 1 a few times a year. Now, can you use the Bio-Regulators? Probably when you're younger, using the Bio-Regulators like Thymogen is going to be helpful to maintain. And as you get older, maybe you need a little bit more.
Yeah.
So the two thymic peptides are thymosin alpha 1, which is really important for immune function. And honestly, immune function decline is probably one of the biggest things that kills all of us, because that relates to cancer and viruses and everything that takes us out. And then number 2 is thymosin beta 4. Think about thymosin beta 4 as our repair thymic peptide. So when I have an injury, when I have I have a heart attack, it's going to come in there to help repair my heart. So that's why you can't, like, as a little kid, you can repair. As a 60-year-old, you can't repair anymore. So if I give thymosin beta 4, I can encourage tissue repair and normal repair, not fibrosis or scar. After you have a heart attack, your heart tissue heals a scar. That's why you don't have good function after a heart attack. If I give thymosin beta 4, I can prevent that from happening. If you add some of the growth hormone secretagogues like hexarelin on board as well, you can really improve that. So hexarelin is an interesting growth hormone secretagogue that you can use that will sort of even more mimic having more normal thymic function.
Interesting.
The question whether you use growth hormone versus growth hormone secretagogues, probably the growth hormone secretagogues are still the safer, better way to go over growth hormone. The studies were done with growth hormone because it was more easily accessible, because it was an FDA-approved drug. So that's why the studies were all done with growth hormone. But the growth hormone secretagogues are still a safer way to go. So I think in your anti-aging protocol, you need the thymic peptides, you need growth hormone secretagogues, and you can cycle them. You don't have to do them continuously.
I love that.
Like what your doctor you were talking about is doing. I cycle things on a kind of more circadian, like looking at 4 seasons and cycling based on what our bodies should be doing in this, what we call circannual rhythms. What's happening at certain times, seasons. We all know about circadian rhythms, 24-hour rhythms, but we don't know about circannual rhythms, which is, well, my growth hormone is supposed to be lower in the winter, right? Why should I be pounding growth hormone in the winter? I shouldn't. It's when my body's designed to be at a low. So the receptors have 40% less sensitivity in the winter.
Because less sun, or what's the reasoning for that?
It's probably simply our body's knowledge of time, so our bodies are pretty innately smart. And so if you look at animals, right? So that's why animals go into hibernation, and is during the wintertime, everything slows down. Same thing happens with us. So it's innately, so probably there's some piece of sun being involved in that, but it's probably more. It's probably deeper.
Yeah. Wow. Well, going back real quick to, we'll say exercise peptides or body, maybe more on the body recomposition side. Do you like or use CJC, tesamorelin? Like, what's the best one?
So those are our growth hormone secretagogues, right?
Yeah.
So CJC is a growth hormone releasing hormone, and then ipamorelin and tesamorelin are both growth hormone releasing peptides. So when you're looking at, instead of using growth hormone, so growth hormone has the downsides that it creates temporarily supraphysiologic growth hormone. Growth hormone gets very high. And the problem with doing that is that, number one, you get what's called receptor involution, where your body gets less sensitive to it over time. But number two, it causes things to grow that you don't want to grow, like your spleen and your liver, right? So when you do these higher levels of growth hormone, you have to be careful with it.
Is there a potential for like proliferating cancer also?
Probably when you're using growth hormone, yes. Probably not when you're using the growth hormone secretagogues. So CJC, ipamorelin, and tesamorelin are secretagogues. They tell your own pituitary to make more and release more growth hormone. So the growth hormone releasing hormones, CJC being the main one, cause the pituitary to store up more growth hormone. And then the growth hormone releasing peptides, ipamorelin, tesamorelin being the big ones, and then hexarelin's fall into that category too. They step on the gas. They cause you to release more, right? So basically you use these, basically using at bedtime most often, because that's when our biggest growth hormone surges happen. And I use a combination of a releasing hormone with a peptide. Think about filling the gas tank and stepping on the gas, right? So basically I use that combination, either CJC and ipamorelin or CJC and tesamorelin. The difference being tesamorelin is a little stronger than ipamorelin. It's a little more powerful. Some people really like that. For me, I actually get side effects with it. I get more edema. I get more side effects from it. I don't do as well. It's probably surges my growth hormone a little bit too much. So it kind of depends on the person. Tesamorelin is an FDA-approved drug. It's called Agrifta. So it's an FDA-approved drug. It's approved for HIV patients who accumulate visceral fat because of the drugs they're on for preventing HIV. And so actually it's a drug to prevent visceral fat. So it's great for your visceral adiposity, people, tesamorelin is. Do I think that those are critical for muscle and bone? Yes. So when your growth hormone levels fall, Even if your testosterone levels are great and your estrogen levels are great and your progesterone levels are great, your bone density is going to drop and your muscle density is going to drop. And it gets neglected. So I have women who come in who have horrible osteoporosis and their hormones look great and their IGF levels are 35. So if you look at our easy way to measure growth hormone, or the easiest way, so the most accurate way of measuring growth hormone is to do what's called growth hormone stimulation test. It's ridiculous. It's really hard to do. So you can measure what's called IGF, or insulin-like growth factor. And IGF levels will sort of give you a sense of what growth hormone is doing. Because when growth hormone is released, it tells the liver to produce IGF, so I can measure IGF. IGF then circulates. There's receptors on bone, on muscle, on immune cells. So it circulates around and does all its fancy things. So I can measure IGF levels. Probably the perfect window is around 170 to 190 for IGF levels, right? But when you start getting into these, I can tell you, I have women who have 35 IGF levels, and their bone is fragile.
Yeah.
It's absolutely necessary for bone density.
Yeah.
So that's an ignored piece, that everything could look perfect in labs and nobody looked at IGF and looked at growth hormone. So it does become a pretty critical player for most people. Not everybody. I have women my age walking around with IGF levels of 250,
Yeah.
So, there are natural exercise induces more of it, but, like my levels without taking any secretagogues are about 111. So they're too low, right? I need more to maintain muscle and bone. So it really is very helpful to utilize those. And usually you can use them one of two ways, either 5 days on, 2 days off, or you can cycle them like 3 months on, 3 months off. I sort of like the 5 day on, 2 day off cycle as people age, because that probably most mimics the way our body is working. But don't downplay those for muscle. Don't play those for bone. It's so critical to recovery. You're not going to recover. If you have no growth hormone for recovery, then you can go work out all you want, and you're not going to recover. You're just going to be sore and injured.
Yeah, absolutely. So if you're only taking tesamorelin then, because like Warren is doing that right now, are we not filling the gas tank and then just pressing on the gas? Is that?
He's young, right? So at a young age, you can get away with that. Right, and testosterone is pretty potent, so it will work. But in somebody who's low, you really want a CJC testosterone combination in an ideal world. But at his age, no, he's going to be fine with just testosterone because he's going to have enough. I don't know what his IGF levels are, but most are really low.
No, they're not. I got to slap his back there. Actually, at the upper range.
Yeah,
which makes sense because he's on that.
Yeah, he's on testosterone.
Yeah.
And testosterone is a great drug.
Yeah.
Have you ever tried it?
Oh yeah, yeah. I mean,
I don't like it. For me, I get.
Yeah, I mean, I've tried it. I just used to do so much at one time that I couldn't parse out
what was working, what wasn't.
What was working,
right.
because
tricky, right?
I was just like, I had enough NAD for like a small village, and I was like doing every peptide like possible, and I was just, so young too. I was like in my 20s, like just loading on them.
Yeah.
I used to do crazy IV therapies too. I'm wondering when these are going to pick up steam, like. Or if they were curcumin and olefinilia, do you know this like olive oil extract? I'm waiting for everything to just cerebrolysine.
And we do a lot of cerebrolysine in our practice.
Yeah, I think it's great. I mean, that is the big one thing that I miss about having a clinic is you just like,
right.
I would just order everything I wanted and then just do it all the time.
Yeah. Right.
I was doing like Ebu all the time and just, do.
Yeah, having access to those things.
It's great to just have all the time.
But there's too much too, right? People who are too blunting oxidative stress to a degree that's, that they're creating damage. There is certainly a point where there's too much. Yeah.
Well, now I'm doing a lot of ovarian age testing. The models are still new and stuff, but I need to parse out therapies so that I can determine what works and what doesn't.
Right.
If I'm doing everything at the same time, like I just finished 40 sessions of hyperbaric. So I have my baseline ovarian age, and then it's this machine learning model that takes some different biomarkers and is trained on like 40,000 non-theoretical data points, et cetera. So I just want to parse out one treatment at a time.
Yeah.
And then see what happens to that number, because I got the best result they've ever seen. But
with the hyperbaric?
No, just in general. My first result was the best that they've ever seen. Yeah. So I had a negative 5-year ovarian age, which, in ovarian age time is like double that almost. And then they usually don't see at 35, based on all the training data, any substantial shifts until you get older. So the biggest that they've really seen is like 1 to 2 years younger ovaries in like a 40 to 40 plus year old woman. So they were shocked by this like -5 at 35 years old. So
wow.
That's great. But because I've done so much now for so long, I have no clue.
Idea.
I mean, most of it honestly is probably because I go to bed at 8 o'clock and I work out 5 times a week and I, manage stress and live in a low tox environment. Like, I mean, I've been talking about this toxin testing stuff for so many years. It's like finally it becomes popular now.
Right.
It's just like, but that's great because I think women in particular need to be looking at their toxin levels.
Yeah. Yeah.
Infertility, these crazy rates of just like every single thing.
Yeah. The infertility is. I mean, I like everybody I talk to is having trouble getting pregnant. It's just amazing.
Well, we're like doused in these toxins that we now know, like PFAS and these environmental toxins accelerate ovarian aging. They disrupt, as we've talked about mitochondrial health. It's just like total disaster. Okay, amazing. So what would your favorite be then for like exercise, like muscle growth? This combo of the CJC and the epimorelin or tesamorelin?
Yeah, I think for muscle growth, if you really want to, I mean, it depends. So probably CJC, tesamorelin. Tesamorelin is probably better just because it's a little stronger, right? One of the keys for muscle growth is you can't take more of these at one time because you'll saturate the receptors and it doesn't matter, right? Yeah. You're just wasting money and actually creating receptor involution. So the key though is if you really want to push muscle growth using the growth hormone secretagogues, which you can do, is to do them more frequently during the day. So if I really have somebody who I'm working with a bodybuilder who really wants to push muscle growth, anabolic status, I'm gonna have them do it, do an injection after workout. I'm gonna have them do an injection around lunchtime. I'm gonna do, and at bedtime. So you have to do more frequent dosing of it to get higher levels of stimulation of growth hormone and that activation of pushing insulin into the muscles. So that's the key to using them for really muscle building. For most of us, it's going to be muscle repair maintenance if we're just doing kind of a nighttime dose. If we're relatively normal. If I have somebody who's very frail, I can definitely help them with just doing that once a day dosing. But if there's somebody like you who's very optimized, you probably would need to increase the frequency to really say, oh, wow, I'm really actually putting on more muscle with these, right? So I think that combination, obviously hormones, being optimized is your first key to muscle. Thyroid hormones being optimized is your first key to muscle growth, and then it's going to be looking at the growth hormone secretagogues as the next stage from there. If you don't have adequate testosterone on board, then you're not going to build muscle, or estrogen for that matter. Yeah. Estrogen's a really big, important hormone for muscles, and we forget about it for muscles.
So obviously you're a fan of like bioidentical hormone replacement.
Absolutely.
Therapy. Yeah. I mean, would you just start once you start experiencing, start with do you usually start people on progesterone when they start to lose that?
I follow it by labs more than symptoms, right? I mean, I never had a symptom of menopause. Never. I never felt, like I couldn't sleep or I had, night sweats or nothing. I mean, I had no symptoms of menopause. So, I think there is a key to, not everybody's doing what you're doing, right? But that we have to start encouraging younger people to be looking at hormones so you see when they drop. Yeah. I mean, most of my staff is younger and we test everybody. And, I have a 35-year-old who has very low estrogen levels already, right? So her estrogen and progesterone are both very low. So, especially again, kind of in our post-COVID world, we've seen a lot of ovarian dysfunction post-COVID and post-COVID vaccines and, and toxins. So I'm kind of in the mind, if I could get 20-year-olds to start checking their hormones, or like they'll say 25-year-olds to start checking hormones and knowing when have I declined? If I know what your optimal levels are and I know when they're declining, I know when to say, okay, we've got to start replacing these things early on. Because as we know, we have this kind of optimal window, right? It's never too late to do hormones, but I'm going to get optimal benefit by doing them the earlier the better, especially for cardiovascular health. Yeah. So how do I know that unless I'm testing it? Because not everybody's going to be having symptoms of not being able to sleep or mood swings or night sweats or hot flashes. Not everybody gets those. So you need to kind of be on track with it. So it is a point where I think we have to get younger people to start getting involved in this stuff. I mean, that's why you're so great, right? Because you're out there as a young person, and people can say, oh, wow, well, she's doing this and she's so young, because most people don't start thinking about this until they're 50, right?
Yeah, totally. I mean, I agree. And that's why a lot of these cool trackers will be really helpful too, to get more of like an understanding. Because the problem is you go to your OBGYN, you're going to get likely the same answer every time because they're not going to ask what stage of your cycle you were in. Right. The woman might not even know. So then you don't even know. So it's like the whole hormone panel, unless you have something significant, it's just like getting tossed out, I feel. Right. It's like not even.
You have to know how to interpret it. You have to know how to look at ratios of things too. Progesterone estrogen ratios, testosterone to estrogen ratios. You have to be able to look at ratios of things too because that helps you even, independent of cycles to look at what ratios should be at different times in the cycle. So, you have to have somebody who knows how to read those, how to understand those. But you're right, it will be really helpful when we have these more like Mirror, things like that, who are doing these more continuous tracking of hormones for us. It becomes, like we've got, be able, if you pee on the stick every day, it's just hard to get people to do that unless they're trying to get pregnant, so you can measure those things. But I do think if we can get better ways of measuring these ongoing with people. I mean, I have 2 daughters, and one is 22 and one who's 30, and just with them who have hormone fluctuations all over the board, just be able to get a sense of exactly what's going on all the time will be really helpful to me.
Yeah, there's a new device. I think it's called Claire. I'll keep you up to date, but it's actually like a wristband type of thing that's supposed to be monitoring. They're going to send me one once they feel.
Yeah, that'd be great. Yeah, keep me updated on that, because we really need that, right?
Yeah,
Really
because I do the Mirror all the time, and for my own, just data collection purposes, but it is not like that easy. And that easy, traveling with like the urine cup and stuff is like, not,
it's not right.
Not the best.
And the only people I can really get to utilize it is people who are trying to get pregnant.
Yeah, totally. Even though I think more people should be utilizing it, because if you don't know if you're ovulating, that's like, you need to know that information as a woman.
That's a marker of your longevity, right?
Totally. And a lot of people just assume that they are, and even if you're having bleeds, doesn't necessarily always mean that you're ovulating. So I think that could be so important.
Yeah, I have so many young and ovulatory women in my practice. I mean, it's scary.
Yeah, I mean, these PMOS now is just like going through the roof, and all these female-specific reproductive conditions. So
I think more endometriosis too.
Yeah,
which is so underdiagnosed as well. And things.
Yeah, and
I just had a woman who has had this horrendous back pain. Right, it's just horrendous. Horrible back, pelvic, pain, and she came to me because her doctor recommended surgery because she had 2 degenerative discs in her back. He said, "Well, we should just do a fusion of your back because she had this horrible back pain." And I was like, "Well, yeah, these are degenerative discs, but most people have degenerative discs, So I did a much more extensive MRI scan study, looked at her pelvis. She had a huge uterus, number one, and then endometrial. You could see that something was going on with the ovaries, and so we went in there and to basically do a hysterectomy because her uterus was humongous and actually putting pressure on all of her nerves of her spine. And then he got in there. She had endometrial tissue all around her spine too. So so she'd been living that way for years and years and years with this horrible pain, and and then was going to have a back fusion, which was not going to help her, right? And so we have to be cautious about these, looking at some of these women who are coming to us with pain syndromes too, especially back pain, pelvic pain, SI pain, and being more cognizant of endometriosis in those people.
Yeah, I mean, it seems like just the worst uphill battle to try to get endometriosis diagnosis. It was crazy. I just interviewed Dr. Jolene Brighton, who is a naturopathic doctor, but she also has these conditions herself, right? Yeah. And so she exhibited signs of endometriosis when she started menstruating, and it took another 25 years. Yeah. She got a million different scans, intravaginal ultrasound, different MRIs. You know what's crazy? What actually ended up catching it for her, and I'm not saying it's going to happen in all cases. Hers was advanced, but she had a Prenuvo, and they flagged on the Prenuvo that hey, this looks like you have endometriosis. And
interesting.
Yeah. So
they're coming up with a new blood test that's supposed to be an identifier.
Oh yeah. Yeah. That's exciting.
Be interesting. That'll be exciting. Yeah.
Yeah. I was chatting with the president of Prenuvo. I spoke with him on a little thing at Eudaimonia, and we were talking about the women's health stuff. And I think I might enroll in this just private thing for now, but eventually that they want to roll out with more better imaging for right now they look for polycystic ovaries and a few things. But I mean, if that could catch more women's health issues, it would just be a game changer, because I think the average time to an endometriosis diagnosis is 7 years or more.
Close to 10 years. Yeah.
It's crazy.
Yeah. And I've diagnosed a lot of it in my back pain patients, because back pain is really one of the,
Wow. That's so important. Okay. Last question before we move on from the exercise. From a recovery standpoint, BPC, what are your thoughts on that? Do you like it? Use it?
I love BPC, usually targeted together with Thymosin beta-4 when I'm using it with the repair. Now, if you're just doing, so again, remember, in my mind, I believe that we should replace all the endogenous peptides that drop with age. So BPC would be one of those, right? So we talked about Thymosin beta-4. Thymic peptide drops with age. Let's replace it. BPC and Thymosin beta-4 cohorts, they work together very nicely because BPC, body protective compound made by your gut. It's an endogenous peptide, meaning you make it, made by your gut, declines when you age. So gut's not healthy, you're aging, lots of reasons, BPC levels drop. So body protective compound, BPC, made by the gut, repairs the gut, but then circulates around, repairs your brain, repairs your tissue, very critical importance to increasing growth factor at the structural level. So increasing growth factors, even like IGF levels at the joint level or at the brain level. So it's very focal effect to increase IGF levels on it, even on its own without growth hormone. It increases VEGF, so it's increasing vascular flow to the areas. It's critical to repair and recovery. And it drops as we age. So you have a lot less at 30 than you did at 12, and a lot less at 60 than you did at 30. So it has this gradual decline. So my belief is it should be replaced. So when I'm looking at kind of cycling my peptides through sort of the seasons, I always think about like spring season, which is kind of our anabolic replacement season, as being sort of a time when I replace BPC. Now, obviously, if I'm injured or training really hard, I'm going to use it during those periods of time too, because it's going to help that. It does work better tied with thymosin beta-4. You don't have to do that way. But thymosin beta-4, whereas if I'm increasing blood flow, increasing growth factors, what thymosin beta-4 does is it's the structural integrity. It's improving actin. So it's basically allowing the structural matrix to be repaired, right? So if I'm increasing all the vascular structure and increasing, I want the matrix to be sound. So think about it as building the new scaffolding. So it's really critical, particularly with injury recovery. The nice thing about BPC is it can be taken orally. Yeah. Right. Yeah. So it's not quite as effective orally, but it can be taken orally. So it makes it a lot simpler of a peptide to take. Yeah. It's particularly beneficial for the gut orally.
Yeah. I've seen, when I was running our clinic, we would put people with like Crohn's and IBS and all these different conditions on the oral version of it.
Yeah. A combination of BPC with KPV orally. Yeah. Huge for the gut. Right.
So good.
It probably works a little bit better for joint health injected. There's always a question, do you inject it close to the site? There's zero evidence that makes a difference, except anecdotally. People somehow feel better when you do it. So I usually have people inject it close to the site if it's an intestinal site. But if you look at the mechanistic effect, there's no reason for that. It's a systemic drug or systemic peptide. It's working systemically. Also, do you need to inject it intra-articularly like Edwin Lee did a study injecting it into knee joints? It worked. He did just 10 patients. It wasn't a lot of patients, but it was effective. I just don't think you need to. I think its mechanism is beyond having to inject it into the joint. Yeah. But if you feel better about doing that, it appears to work.
What is the peptide regulatory landscape right now? So, really from when I was hands-on, peptides were available and then they were taken away. Right. Are they back now, or was that just...
So right now we're kind of in this gray area, right? So we all got excited when RFK announced that we were moving peptides from category 2 to category 1. And everybody got, oh, yay, peptides are back. I can tell you I'm on one of the advisory boards working with this and trying to move these peptides from category 2 to category 1. And it's still a long process. We're in a gray zone, meaning that they're kind of letting us do things right now while we're in this gray zone. But we're not there yet. And each peptide in of itself has to be presented and approved to move from the category 2 to the category 1 phase. So even though they've now put this into the, we're looking at it phase, meaning it's opened the door a bit for us to do things, in a more, safe fashion from a logistics perspective. We're not there yet. So we're still, in July, there's going to be a big, a big congressional meeting talking about these things. We're trying to present more data. The problem is they really want human data. And, and human data is still sparse for most of these peptides, right? I always lecture about, do we need, human data and things? To get all the human data collected is just going to take too long. And, we know these have been being used now for years and years and years very safely. 10 years. We know their mechanistic effect in animals and how well they work. So we know their risks are low. Millions of people have used these at this point. So we have all this data to present, yet we don't have these, double-blind, placebo-controlled studies yet. We've been trying to create a database where physicians are putting in this information so we can collect more data. The problem there is getting people to put, it's an extra step now. I have to say, now I've got to put everybody, my patients, into a database, mark out, this got better. It's demanding on somebody's time. And so we're finding it very hard to get physicians to input the data, to even collect the data, to put it together and have a research company put it together for us and present it. So we still have a long way to go. I don't think peptides will go away. I think the demand is high. I think, right now, I don't know when we have a new administration what will happen, but with RFK around, he's certainly a very pro-peptide guy. So right now we're in that gray zone where we certainly are utilizing them. I've been doing peptides for a long time. I mean, we went through a period where like we bought out all the peptides because we're like, oh my God, they're going away.
I know.
We bought them all out, and then they didn't go away. And so we've and so I don't see peptides going away. I hope that we can get them more and more legitimized from a standpoint of legality, but I don't see them going away in any time.
Yeah, there was a time where I felt like I was crying wolf all the time because
over and over
we
again.
would call the patients like, it's going away. If you want it, you stock up.
Exactly. Right. We did that, right. You're like,
I was
okay.
like, I swear that I'm not just calling you to tell you this to make a sale. Like,
we did
I
the
really
same thing.
thought
we had this massive, like, okay, these are all going away, and people bought all these peptides, and then like, oh, they never went away. It's like, oh, well.
And it's like, oh, they're going away again. Just kidding.
Yeah, we did the same thing.
Yeah, I know. I was like, that's it. I'm not making any more calls because I just feel like I'm like lying in a salesperson right now.
Yeah.
It was not
it's like it's sort of like and then people think you're just trying to sell something, just like the stores are like, this is the last 10 we have of these, right?
Oh, that's funny.
I do think the regulations are making it much more difficult for the research chemical companies. Honestly.
Yeah, I mean, the main one, I mean, I never ordered anything from there, but the Peptide Sciences thing,
right.
That's like gone, yeah?
Yeah, well, it kind of rebranded.
God, of course.
So it's actually still around, but rebranded. But they certainly are making it a little more difficult for the research companies, which I'm happy about.
Me too.
And not everybody is, but
yeah, there should be more I mean,
right.
Like, I'm not a fan of regulating what you can and can't use,
Right.
but I am a fan of protecting people from themselves because people buy things and you think if it's on the store on the shelf or you're able to purchase it that it's safe for you,
Right.
and that's not the case.
Right.
So,
Exactly.
Yeah. Okay, let's talk about joint health. So, and we might have already, done some of this throughout the conversation, but like if you had to build the perfect joint protocol for someone, let's say starting in their 20s, like what would that look like? And then, what about all these supplements? Is collagen good or not great for it? What do you use personally? And then we'll get into some more of the more like regenerative side of things.
The key is that you have to get out of your head that this joint disease is a wear and tear disease, because it's what all the orthopedic doctors tell you is you just wore out your joint, you exercised too much, you played football, whatever it might be. It is not. And we now have 2022, a great 5,000 person meta-analysis study following people over 18 years, looking at active people versus non-active people. By far, the non-active people developed significantly more osteoarthritis. This has nothing to do with joint load, joint wear and tear. You have equally as many big football players who don't have any joint disease as do have joint disease. It has nothing to do with that, nor does it really have to do with body load, right? A big fat person loading their joints is going to have a higher level of osteoarthritis than a really muscular big person, right? So it's not the load on the joint, nor is it the wear and tear on the joint. This is a disease process, just like your brain shouldn't wear out from thinking too much, or your heart shouldn't wear out from beating too much, your joints shouldn't wear out from using them too much. There is something pathologic going on if they are.
Even running too, because
running well established, except in the long endurance runners. And the reason for that has not to do with the wear and tear aspect. It has to do with the long endurance runners are in such a chronically inflammatory state that they're creating problems. But the other runners actually had a slower rates of lower rates of osteoarthritis. And when they looked at cartilage on MRI scans and biopsies, they found that people who ran had less cartilage damage than people who did not exercise, who were not, So long endurance, because long endurance exercise is not particularly healthy, right? It's a great adrenaline thing. I love that, I used to run marathons. It's a very great feeling of accomplishment, but running 50 miles is of no good to your body. Right? And that's doing damage because you're creating such a high inflammatory state during those times. So that's why the running kind of gets this bad rap, is because yes, if I'm running in a state where I'm creating so much inflammation, then I'm going to have problems. But it's the inflammatory problem that's at the root of the disease. And ultimately, it's at the mitochondrial level.
Interesting.
So, now are there genetic people who, are you more genetically prone to osteoarthritis? Yes, because you can have, for instance, COL1A gene abnormalities that your collagen is just more susceptible to when there's bad things going on. It's going to be more susceptible. Does trauma affect this? So if I tear my ACL, why do I have an 80% chance of developing osteoarthritis? Well, it's because that inflammatory state went up, and for some reason it did not turn off. And again, genetic reasons for that, lifestyle reasons for that. So lots of reasons for that. So we're not going to say it's all that, that you're just metabolically unhealthy. Something is going on that's created a metabolic imbalance. Now, again, genetics play a role there. There are people who make higher levels of something called interleukin-1 beta. It's a cytokine that's very linked to osteoarthritis. There are people who you genetically just make more. So that person can tolerate a lot less stress, a lot less metabolic stress, a lot less stress in their life, a lot less, having anything go wrong with them, having an injury. They're going to have more problems. But at the root of all of this is that we've got to get out of our head that this is wear and tear and start thinking about this as a disease process, just like heart disease. So if I looked at somebody who had a joint injury, for instance, that person needs to be addressed right there and then at saying, okay, we need to get your inflammatory state under good control. If I have perfect hormones, perfect thyroid, perfect micronutrient panel, right? My mitochondria are healthy and I have an injury, I'm going to do pretty well. 90% of people aren't in that category. Yeah. Even my 18-year-olds, right? In fact, they may be the worst. They're eating like shit. They're under a lot of stress, social pressures. They're not sleeping the right amount of times, right? So they get 18-year-old gets that injury now, and they have surgery, and their body stayed in an inflamed state, and now 50 years later, they have horrible osteoarthritis in their joint. Yeah. So what do we need to do? We need to actually look at treating these as a disorder that we need to optimize health just like everything else you're doing. And instead, we're looking at it as an isolated disease state. Even in the functional medicine world, if somebody hurts their knee, your functional medicine doctor doesn't go, come in, let's get you taken care of. They send you to the orthopedic doctor. Yeah. And really, they should be the first person treating this because they should get the inflammation under control. So mitochondria, key. We often thought mitochondria were important in joints because we thought, well, they're pretty avascular. That's why cartilage doesn't heal. It doesn't have much vascular supply. Chondrocytes don't have much vascular supply. But it makes mitochondrial function even more critical there. That the few mitochondria that are there for energy production are really vital. So when there's damage to them, now you've lost energy production to the chondrocyte. So we now know that chondrocytes are really energy dependent and that ATP function in chondrocytes is really important. So when I look at how I'm going to prevent these diseases, it's everything else you're doing right. It's going to be, are my hormones completely optimized, right? So estrogen protected the joints, progesterone protected the joints, testosterone protected the joints. Is my thyroid perfect? Because thyroid's critical to mitochondrial function and to estrogen function. So those are all playing back a role in the joints. Are my nutrients adequate? Do I have vitamin D, K2, magnesium on board? So all those things that are just critical baseline players, the B vitamins, baseline players to my function of my chondrocytes, have to have all that in store, right? So those are my first line to prevent. You talk about what are you going to start doing in your 20s? You're going to be making sure all of those things stay well, from a nutritional aspect, from a sleep aspect, so just like every other disease. And
you probably see this, you can be eating a healthy diet and still have, micronutrient suboptimization,
very much so,
because I don't think rarely anyone, actually, I don't think I've ever seen anyone other than myself post like on a consistent basis or even just once micronutrient testing, like the cellular.
We do it on all of our patients, right?
Yeah, no, I'm sure you do, but I'm saying
but
it's
most
not.
People have no idea, right?
Yeah, most people have no clue.
Nutrients are deficient in, right? And that's a problem because you're right. Most people come into us with micronutrient deficiencies.
Yeah, I mean, I have like as close to probably like the perfect Mediterranean. I eat for health.
Right.
I don't eat out. I make every single meal at home. I do all the things, but still, I test my micronutrient profile 4 times a year, and there's always something that can use a little bit of modification, right? So,
and if you look at intracellular, micronutrients too, right? It's not just looking at what's flowing around your bloodstream. So if you're measuring B12 and just flowing around your bloodstream, or red blood cell magnesium, it's better to look, at intracellular levels of things. So you've got to make sure that those are all optimized, and so that's that's starting place. From a easy anti-inflammatory perspective, omega-3s, right? So, omega-3s are going to, even if people are eating too many omega-6s, at least we can balance that out by pushing the omega-3 levels up. And that's so anti-inflammatory overall to the joint. So those are all baseline things that you start with in your 20s and your 30s, to just prevent disease. Now,
do you aim for a certain omega index with your patients, and what would be the best for joints?
I don't know that it changes for joints as it does for overall health. And so I think that you're going to keep your same indexes that you would use for your general health person. I think where the problem lies right now and why we're seeing such an epidemic of osteoarthritis is that we aren't treating the acute injuries appropriately. So if you look at what we do when you injured, like you sprained your ankle, we still stick with the old RICE protocol, right? Rest, ice, compression, elevation. We now, even the guy who invented RICE said, actually it was wrong. Because what does rest do? Number one, if you stop all mobility, things stiffen up. You don't get growth factors to the area. You don't get blood flow to the area. So you actually want to move as soon as possible. Now, obviously, I'm not going to have you jumping around on your broken ankle, but I'm going to have you trying to move your other joints, getting on the bike with your other leg, doing upper body work. I'm going to keep blood flow going. So you want to keep people moving. You don't ever want to put them at rest. Ice, worst thing you can do acutely with an injury, because ice constricts the blood vessels. It actually makes it harder for all these little healing things that need to get there. Remember, we want that big inflammation. We want that to occur. We just want it to occur for a couple of days, right? Compression, same thing. I don't want to compress an area that I want blood to get to. Yeah. Elevation's fine, but you don't want to put compression on there. I want to get blood flow. I want to get movement. So really what we have is more the meat protocol. It's, movement, exercise, anti-inflammatories at the appropriate time, right? And then PT training to try and get the recovery back. So we kind of do more of a meat protocol now instead of a RICE protocol. I tell people, so with my patients, what I say is that first 3 days, I actually want you to be inflamed. I want, it makes sense. Yeah, it makes sense. That's what your body's doing. It's like why a fever occurs when you're sick, right? The fever's a good thing. We always say fevers are a bad thing. They're actually a good thing. Unless they get too high, they're fine. It's okay to have a fever. It's okay to have inflammation. What we want it then to do is after about 72 hours, we want it to turn off. And here's where the problem lies. We're turning it off early, right? And then we're setting the stage for this chronic inflammatory state. And what we want to do is get this inflammation, then we want to turn it off after about 3 days. So at 3-day mark, that's where I'm going to start pulling things in. And one of the easy things that you can pull in is actually a low-dose aspirin. So if you take low-dose aspirin with your omega-6, your omega-3s, there's this little-known pathway called the aspirin-mediated pro-resolving mediator pathway. So you've probably heard of the pro-resolving mediators, SPMs.
SPM, yeah.
So those are critical to turning off the inflammation process, right? So they should turn on in about 3 days, and that stops that inflammation from ongoing. So I'm going to accelerate those. You can take SPMs, but they're expensive, and they probably actually don't work as well as making your own. So the way you make your own is take omega-3s with a low-dose aspirin. That turns on this aspirin-mediated pro-resolving mediator pathway, and you pound these resolvins that are going to actually now turn off inflammation. So at 3 days, I have people take low-dose aspirin and high-dose omega-3, like getting into the 3 or 4 gram range. And that starts turning off that inflammation phase, right? And you'll see that they improve quite rapidly. With so much data now that when you hit people with anti-inflammatories, like after surgery, they take longer to recover. They don't recover as well. There's tons of data on that. It's not out there. First thing people do is get Motrin when they have an injury. So that's kind of first stage. We need to reset our thinking about these injuries, right? And that way, if I could get everybody on these different protocols at the time of their injury, and even if I have an ACL tear, I'm going to refer you to the surgeon. You still need surgery, but I can now take over afterwards and start changing this whole process appropriately so you heal well. We also use, and this is actually a drug. It's not a peptide. It's called pentosin polysulfate. Pentosin polysulfate is a drug in other countries like Australia. It's called xylosol. It's in phase 3 trials here in the U.S. As what we call a DMAO, which stands for a disease-modifying agent of osteoarthritis, meaning a cure for osteoarthritis. And it's a very unique element because it addresses all the things that go wrong in an osteoarthritic joint. That's really a disease, right? So what pentosin polysulfate is, it's a glycosaminoglycan that's similar to what makes up the collagen structure of your joint. But it's a semi-synthetic product. It helps improve blood flow to the area. But the main thing it does is it turns off 2 enzymes that get turned on when you have ongoing inflammation. One is called an ADAM-T enzyme and one is called MMP3. And those 2 enzymes are sort of the destructive things. In fact, ADAM is what's called a destructin. It's actually trying to tear things down. If you think about what happens when we when we have inflammation, we have all these little cytokine particles and cartilage particles and all these things going on. So think about these enzymes as the Pac-Man. They come to clean up. The problem is if they don't turn off, it's a little bit like if I scrubbed my wall and got rid of the spot and I kept scrubbing, now the wall's gone.
Yeah.
So the big problem is these two enzymes stay turned on. Now they're destroying your cartilage, your bone. So what we can do is start using Pentacin now to turn off these enzymes, right? To help increase blood flow to the area and to prevent the progressive osteoarthritis. So used early, like post an injury, post a surgery, hugely beneficial in preventing osteoarthritis. But used in the patient who already has osteoarthritis, actually we're seeing 30% improvement in cartilage structure over a year in these people. We're actually seeing cartilage regrow in these people that we never thought we could do. We're seeing improvement in where there's destruction to the bone in people who have severe osteoarthritis. We're seeing improvement in that.
Wow.
So truly, in about 80% of people, you can stop and improve their osteoarthritis. So it will get FDA approval probably in a few years, 3-4 years, for osteoarthritis of the knee. But we can get it now because it is a drug. It's a drug called Elmiron, which is an oral medication for bladder inflammation.
Oh, interesting.
And what we found is when we turned it into an injectable, that it works really well for joints at a very tiny dose. So you use a much smaller dose, and you do an injection twice a week of it, not into the joint, just systemically. And it turns off these horrible enzymes. It increases blood flow to the area. It's potently anti-inflammatory. So Pentacin polysulfate has studies now as an anti-cancer agent, as an agent to improve blood vessel diseases. It's been shown to kind of turn off inflammation everywhere, including brain, and really helpful for gut as well if taken orally. So it's a really critical compound that nobody really knows about and uses about, and it's been a life changer for myself and so many patients to utilize this. And doctors don't know about it. Now, eventually they will. This will get FDA approval. It will. It's just taking a long time, but probably 3 to 5 years we'll have it. Who knows what will happen to it cost-wise? I don't know. Will insurance pay for it? I don't know. Hopefully we'll still be able to, but it's not an expensive thing to do, and it's really beneficial to people. So if I have my young people who come to us with an ACL injury, what we're going to do is get the joint fixed, start them on this protocol right away, and they recover so much better and so much faster.
And then how are you? So you're able to just like order the second version.
We get it compounded.
Okay, got it. Yeah.
Yeah. So we have a compounding pharmacy make it. So they can take the compound that, Elmiron is made of Pentacin polysulfate. So that compound exists. It's an FDA approved compound. So very easy to have them turn it into just a injectable form.
Nice. That's great. So incredible. What about, would we say then exercise is actually beneficial? So we're not wearing out the joint, but it's actually beneficial.
Right.
And then obviously keeping a low inflammation state. Outside of markers like maybe HSCRP or TNF-alpha or IL-6, is there anything that's joint specific? I think you mentioned one that you're
IL-1
testing
beta, IL-1B is really important to look at as a marker. IL-1 beta is also really important in heart disease. It's why people who have joint disease oftentimes have heart disease as well. So if you look at somebody who has osteoarthritis and you look down the road, they have a 70% increase of having a cardiac event. And people used to think that was just because they were exercising less, and that was why they have cardiac events. It's now been shown that even that with that factor taken out, that they still have increased cardiac events. So that high IL-1B is really damaging to heart too. So this is not a benign disease. If you have osteoarthritis, this is not a benign disease. It means you have high levels of these inflammatory markers, IL-1B being the biggest one. You won't always see IL-6 elevated or TNF-alpha elevated. Those are more in like our rheumatoid arthritis people, you'll see that, but not so much in the osteoarthritis people. But IL-1B is a big player here, and that's where Pentacin actually blocks interleukin-1 beta. There's not a lot of interleukin-1 beta blockers out there. There are some, but they're expensive. They're hard to get, and that's one of the things that Pentacin can do is block this interleukin-1 beta.
Wow.
So so you can measure IL-1B levels. It's going to, the problem with a lot of these things is to really look at like your high levels. You have to look at in the synovial fluid, so you have to aspirate the synovial fluid and look at it there. So you can kind of assume if somebody has an inflamed hot joint, they probably have high levels of IL-1 beta.
Wow. Supplements, what supplements would you recommend?
So I like collagen. I was very much a sort of, when I was in my orthopedic, days, I was like, no, collagen's stupid. You can't eat collagen, make collagen. The studies have shown otherwise. Collagen hydrolysates, which collagen peptide basically is a collagen hydrolysate. Now there's ample studies to show it improves healing, it improves function in joints. They did a great study on patients with knee osteoarthritis. Their ability to stand longer, walk longer was in 80% of people dramatically improved. They did a study with high-level athletes with ankle sprains, and they improved the recovery was twice as fast, and they had over the following year had less likelihood of re-injury. So I am a big fan of collagen hydrolysates. You're best taking a collagen with vitamin C. So vitamin C is really important to take with your collagen. A lot of them will have it in it if you look, and you do want to look like Fortigel is a patented type of collagen, so I like that as the collagen hydrolysate. It just has more data behind it. So I usually find a supplement that has a collagen hydrolysate like Fortigel combined with a vitamin C, because if you take those two together, you're going to accentuate the effects of the collagen. Vitamin C is really good for joints in and of itself. If you look at vitamin C for tendon and ligament healing, using so if somebody has an injury, using IV vitamin C, even like a 10-gram dose, really helpful for certain healing too.
Wow.
But making sure you have adequate vitamin C on board all the time is going to be really helpful to collagen levels as well. Remember, you have to be careful because vitamin C will, if you have somebody who has high iron levels, vitamin C will increase iron absorption. So it's great if you have somebody who has low ferritin levels. If somebody has high ferritin levels, that becomes an issue. But in general, think about vitamin C for joint health, particularly for the tendons and ligaments, is really helpful. So I think it's an underutilized recovery is to use IV vitamin C in those patients.
In terms of collagen types, I think there's multiple, right? Is there a specific collagen type? Do we want all the collagen types?
Well, it's probably your best bet is to do just a coxcomb, like a full collagen matrix, and then combine that with a type 1 collagen, and that's where the Fortigel comes in. But if you can do if you look at some of these compounds that are just eating coxcomb and things like that they're made out of chicken cartilage, that are full cartilage matrix, and they make them into some, I have a little drink one that doesn't taste bad. Bone broth. Bone broth can be super helpful there.
Okay.
Especially
nice.
if you just throw the bones in there, and that's it. So that's great. So, and then do that with like a Fortigel collagen one, along with it, probably to get the best benefit.
Amazing.
But I think the data is pretty compelling now on collagen, and I think glucosamine and chondroitin, which are widely used for joints, are a mixed bag. Remember that glucosamine is a glucose molecule. It can raise blood sugar in some people. I do think some people seem to get benefit from it anecdotally. I think jury's out from clearly whether they're truly hugely beneficial. I think your omegas, as we talked about, are really, really beneficial. I think anti-inflammatories like curcumin. I like what's called bisdimethoxycurcumin or BDMC a little bit better, just because absorption seems to be a little bit higher for joint health.
Nice.
But so I think that can be really helpful. And, and then again, it's sort of your basics, your magnesium and vitamin D's from joint health. But I think vitamin C gets really underutilized. If you look at Ehlers-Danlos people who have really severe collagen laxity, right? Or, people like me who just probably have bad collagen. Vitamin C is, the studies on vitamin C in Ehlers-Danlos patients, you have to do high dose. They have to give themselves an injection of a gram a day or so. Then we saw marked improvement in their joint structure.
Oh, that's wonderful. What about, are there any peptides for joints specifically? Maybe the BPC?
BPC and TB4.
Yeah.
And then the other one that comes into play there is GHK copper. So GHK copper is really, it's a 2-3 peptide or amino acid peptide. It's really critical to collagen repair. So GHK copper, ideally injectable, but if you can't get it injectable, it's all over topically for skin, so you can get a lot of topical preparations of it. And if you do it over a joint that's painful, you can get some absorption intra-articularly into the joint. That's painful. So using GHK copper is also really a nice add-on, particularly post-injury to help it recover, because that's what takes collagen kind of to the next step to allow it to actually not form scar, but to form normal collagen in recovery. So it's great for wounds as well.
Most people, I think of it for skin.
For skin,
health,
right. But skin is, collagen, right? So that's really what you're doing with GHK copper. It's really, there's over 500 genes that are modified by GHK copper positively, and that are integral to kind of our overall health in general. So it's really actually a more valuable peptide. I think that gets underutilized from that perspective.
Yeah. I wish it didn't burn so much.
It does.
Any tips?
So some of it depends on who compounds it.
Yeah.
So, when you get burning and peptides, it's usually a pH issue. So some of it depends on who compounds it. You can mix a tiny bit of bicarb with it to keep it from burning. Or if you make sure you're really alkaline. So if you do, like before you inject your GHK copper, like 20 minutes before you drink Alka-Seltzer. So I love Alka-Seltzer, sodium bicarb. Basically, make sure you get the one that doesn't have aspirin in it. But just sodium bicarb is so good for the more alkaline our joints are, our health, our systems are, our immune systems are, the better off we are. So the more alkaline I am, the less likely I'm going to get a response from the pH response of these peptides. So if I have more alkaline people, I'm going to get less of this response from this burning of peptides. So I always look at alkaline, what are people's CO2 levels? Make sure that CO2 level is around 26, 27. Then that tells us that person's in a more alkaline state. They're going to be less likely to get these reactions.
I think, because I never remember it burning so much, but the most recent bio that I have, it's
I think so. I have one compound that really burns, and one compound that doesn't burn so much.
It'll even bruise. I was like,
really bad. Like like the burn doesn't just go away.
No, it stays. Yeah,
it stays. And it's painful, and you get bruised.
I had to back off of it. I'm like,
yeah, and I do think that is somewhat of a compounding issue too.
Yeah, good to know. Regenerative treatments for joints. First, I would love to talk about cortisone, because that's the default in Western medicine, right? We used to do ozone injections. Curious, I think there's many people that still don't know that. I think cortisone, maybe you have a different opinion, but cortisone is negative over time. And then what are some of the regenerative options, starting with like basic, and then I've had, I had a small little, I don't know, just strain on the top of my knee here. I was a gymnast, I was a cheerleader, dancer, all that stuff growing up, ran track, super active, have been lifting heavy my whole life. I've had stem cells, different varieties of stem cells, from V cells to exosomes, injected in there. And it seems to work it takes years, but it'll work for years. So curious, what are you doing with your patients? What are you thinking works? And
I think the thing that bothers me the most about some of these regenerative people who are doing a lot of regenerative therapies, when you look at these clinics that are just set up for regenerative therapies, is when you try and do regenerative therapies in somebody who's not optimized, it's not going to work. And so you have these people who are, not hormonally optimized, not thyroid optimized, not nutriently optimized, not sleeping, and you decide you're going to throw stem cells into their knee. It's bullshit. It's not going to do anything.
Costs so much money too.
And how many doctors are doing that? I mean, it's all over the place. Most orthopedic practices now have added PRP stem cells into their clinics, and it's just dumb, and it's a waste of money. So obviously the first thing you have to do is make sure people are optimized before you do any regenerative therapies. So obviously we're going to make sure that everything's optimized, but then you're going to actually spend some time getting the joint into a state where it's not going to it's going to be able to respond appropriately. So usually we will use a course of Pentacin before we do the procedure, because now what have I done? I've turned off all these inflammatory processes that are going to go and destroy all the work I'm trying to do. So if I put platelets in, the first thing I'm going to do is get a little inflammatory reaction, right? Well, if that stays up, then you'll see the platelets just, like anything, make things worse. So if I have a course of Pentacin on board, that doesn't happen. I don't see this destruction stay up. I see a nice little inflammatory response. You stop it a few days before, 3 or 4 days before the procedure, because it's a weak blood thinner. And then resume it about 3 days after, right? Because I want that little inflammation and I want it to come down. So about 3 days after I start the Pentacin, I go through my aspirin protocol, Omega protocol. So just like treating it as an injury. So those are things you definitely want to add in when you're doing these regenerative procedures. As for which regenerative procedure I like, it's across the board. It's very different, right? So we've got platelets, which at this point, PRP has been well established as there's pretty hard to deny it's not effective. The problem with it is your platelets are only as good as you are. And so it's something like you who's young and healthy, probably you've got great platelets, and and you're going to do pretty well with just something as simple as PRP or platelet-rich fibrin matrix. When you're somebody who's 50, 60, maybe not as healthy, even a young person not as healthy, then you're not going to get as good a response. Your platelets don't have the active growth factors. Things are not going to do well. So when we take a 60-year-old who's, who has elderly platelets, and, they're not going to do so well, right? Yeah. So that's where you have to pull in younger cell treatments, like using exosomes from, umbilical or placental sources. Certainly where you're getting more youthful growth factors. Remember what exosomes are? They're the guts of the stem cells in a sense, right? So the stem cell, the way it works is by excreting exosomes, and the exosomes travel around and act as the messengers. So really, as good as stem cells are, exosomes are better because I can condense a whole lot of exosomes into a small space, more so than the stem cells. So I think exosomes for my patients who are, elderly, sickly, still remains a much better treatment source. And I like them, and they work well as long as they're in the optimized person.
Mm-hmm.
Things that I think are really cool and are underutilized. One is something called alpha-2 macroglobulin, or A2M. A2M is basically it's a protein that you make, alpha-2 macroglobulin, and it is the thing that's cleaning everything up. But some people systemically have just lower levels. So if you have an injury, your body makes A2M, it goes to the site, and it cleans everything up. It gets rid of all that bad cytokines I just talked about. It's the thing that's designed to turn off that inflammation. But if you systemically or genetically have lower levels, or you're unhealthy and have lower levels, or if you just have a more chronic injury, not enough of it can get there. So what we can do is take a bunch of your blood. We run it through a filter that is a pore size that filters out the alpha-2 macroglobulin. You take a fair amount of blood, and you run it through this filter, and you filter out the alpha-2 macroglobulin, and you inject that back into the joint, and it's remarkable. It just turns off the inflammation.
Wow.
Right? And people, lots of times, once the inflammation's turned off, they just start recovering. You don't have to do anything more. Sometimes you stage that with turning off all the inflammation, getting everything in a really good place, and then adding in platelets or stem cells or exosomes. But it's a really underutilized tool. Not a lot of clinics do it, and I love it. It's a great treatment. I do it in spines. I do it in knees, shoulders. It's pretty amazing. It's a little more technically difficult, just a little more tedious process. They are coming up. Cytonics is hopefully coming up with a synthetic A2M. So we'll be able to pull it off the shelf and inject it, which will be really nice.
Nice, yeah. And
then the last thing that I'm really kind of interested in, and I've only done it myself at this point, is using a secretome made from, the company Acorn, which I'm sure you're familiar with.
In the fridge.
Take a hair follicle, right? You take 50 hair follicles. And the hair follicles are a really robust source of stem cells, probably better than your bone marrow or fat because they're actually regenerative. They're more active. So they actually are a better source of stem cells than probably your bone marrow or fat. And Acorn's great because once we pluck these hairs from people, 50 hairs, we send them to them. They isolate the best hair follicles. They take the stem cells, and then they make what's called a secretome out of your stem cells. So basically, they isolate the IGFs and the VEGFs and all the best growth factors out of your best stem cells. So now you've got this little vial of your own healing factors. Everything good that's going to heal you is in this little vial, lyophilized for you. And it's approved now for hair and skin. But when you think about that, isn't that what we want? We want all of these healing factors, and ideally endogenous to me, what my body recognizes, right? Because exosomes contain the same things, but is there some foreign aspect to them? Maybe. So if I can truly use my own secretome, will I get more benefit? So the only person I've done this to so far is myself, because it's not approved in any way yet, and they don't have a lot of data on it except in animals. In animals, it was amazing. So I've actually said a really bad shoulder, and I would tell you it was potently anti-inflammatory. Literally, I've done it twice now, and every time I've done it, the inflammation, first time I can sleep at night without pain, I can move my arm without pain, and then it's gotten a little better, but so far it's kind of come back to its baseline. I think what we're going to have to do in working with this is the secretome have to be injected a little bit more frequently, like maybe every couple of weeks, injecting it in to get to a certain point. But it sort of makes sense that your own secretome, your own growth factors, the best of you, injected is going to be the safest, maybe most effective thing. But we don't know that. We don't have the data yet. But I think that's going to be up and coming, something to keep an eye on. Right now, my go-to is typically using A2M, using exosomes in younger, healthier people, using platelet-rich fibrin matrix, and we get great outcomes with that, as long as we are optimizing using all those other techniques we did. And again, following that, after you do the regenerative procedure, you're going to put them on BPC and Thymosin beta-4, right? Because those are going to encourage everything I've just put in there to really work.
Yeah. I mean, I love that. Cortisone, do you do that or not?
So cortisone, I'm guilty of injecting tons and tons of cortisone through my career as an orthopedist. What you have to remember about cortisone is it's potently anti-inflammatory and potently destructive. So it's turning off everything, all your ability to heal, all your inflammation. So it works great for making you feel better. At the same time, you're turning off everything that allowed you to heal. So we absolutely, with 100% assurity, know that it's destroying cartilage. Now, if you do that once, probably you're going to be okay, right? If you're doing that like I have patients who literally go in every 3 months for a steroid injection, you are going to hasten your destruction of cartilage. We absolutely know that. The studies are, and studies are robust, like in the hip, which is particularly vulnerable because it has a low vascular supply. In the hip, even one injection in a fair amount of people will cause cartilage damage. So you're paying the devil. You're going to get reduction in inflammation temporarily and pay for it by you're losing cartilage. So it really should not be done. There are times when I have somebody who has some huge, it probably is the most tried and true way of getting your pain relief fast, right? So what I will do sometimes is I have somebody, they've got some huge event coming up, right? And they've got to be able to walk and their knee is horrible. The fastest way I know to get them better is to put a little steroid in there. I will do it once and tell them we're not ever doing this again. But if you need this right now, you've got an opportunity. I'm not going to be doing this anymore. Is this the opportunity you want to use it? So I'm not going to say I've never used them. I will use them. I've used them way too much in my life. I think doctors need to warn patients that the disastrous outcomes that are possible, right?
Yeah.
That you are exactly paying the devil. But again, sometimes it's worth paying the devil. You've got a wedding coming up and you can't walk.
Yeah.
Maybe it's worth paying the devil for those.
Yeah. Yeah, that makes a lot of sense. People that are traveling outside of the country to do some of these spinal stem cell therapies, some people that I've been aware of have had not good outcomes.
Right.
I've been invited to do these many times. I have not gone. For a lot of reasons. Number one, I'm young. I don't think I need to do it right now. But also, seems like there's a lot of risk. Why do we think some of them are going so badly?
Well, when you look at the most recent cases, right, out of one specific clinic, where a host of people came forward with having horrific infections, and they actually targeted it down to actually finding Giardia in some of the people, so was actually injected into them. I think the problem is the sterility of a lot of these places is not great. When you look at the water sources, the environmental sources, even in the best of hospitals in some of these other countries, and when you look at Costa Rica and Mexico and all these, even the best of cases, the sanitation is just not as good, right? So we're going to these countries because we can legally do things, but are we at the risk of, is the risk higher? I believe so. I think that it's great to have the opportunity to go places and do things. I hate that we can't do them more in the U.S. But if you've traveled around a lot, I can tell you even the best hospitals, when you walk in there and you look at, I had a friend, or one of my son's friends, who had a horrific femur fracture in a foreign country, and the first hospital was horrible, but even when they took him to the best hospital, it was not great, right? It was not. So I think you have to be really worried about sanitation issues, even in the people who are handling your things, the hands of the people who are handling things. I think the sanitation is not great. We very much know that the ability to keep sanitation good in some of these countries, especially the countries that are doing this for the most part, it's just not as good. So I think that's where the problems lie. I don't think it's necessarily the bad physicians, or I think that most of the techniques are probably good. For the most part, do I think you're probably going to be fine? Yes. But do I think it's a little bit like the research peptides? Are you willing to gamble? As you and I both know, like the famous doctor who had treatments and had ended up almost paralyzed. I mean, it's a little scary because the outcomes are disastrous if something does go wrong.
Yeah.
So where do you go with that? Do you take the chance? It's cheaper. It's more available. Do you take the chance? I think it depends on your risk tolerance. I don't know that I have that risk tolerance.
Yeah. And is the main reason why people are going there is because you can get like the young stem cells, and
right, you can do things that aren't available here.
Yeah. But if that was available here, would that be part of your practice?
I think that when you look at things like young stem cells, I think exosomes are probably better than young stem cells, right? They don't have any of the DNA information. They have lower risk of any kind of downsides, and exosomes are young stem cells are taken from placental or umbilical sources usually. So I think that exosomes still, which we sort of can off-label use a little bit more. So I think they're safer than stem cells. So I don't know about that. So it depends on what we're talking about. Most of the things right now that I see being done in foreign countries is short of probably some of the gene therapies. I think that we have better options still here to be able to do. I don't think we need to travel to foreign countries. I think the exception, there are things like, I do think some of Europe has, for like plasmapheresis filters.
Yeah.
I think they have some better options for being able to filter blood, like ionospheresis and clarify filters and things like that. I do think they have some better options in terms of blood filters and things like that I would travel to other countries for.
Yeah. I think that I invested in a company that's trying to bring ionospheresis here.
Yeah.
So I get like the updates. I think, that they've been working with the FDA for a while. So I'm really excited about that too, because obviously I like the idea of getting bad things out of the plasma, but then you're taking out all the plasma.
Blood. Right,
and
exactly.
then, I travel
it
so
makes
much.
more sense, right?
Yeah.
To be able to filter out and I just was reading about some Swedish doctor who's found something that really filters out some of the p-tau, which will be huge for Alzheimer's. So I think that those things, when I travel to another country for those, in terms of gene therapies, where am I with those right now? In terms of some of those, I think we still have a ways to go. I don't know how you feel about the gene therapies, but I think it's still.
Yeah, I mean, I have been able to do those too. I've turned it down for a bunch of reasons. I mean, for me, again, age is a big. I mean, if I was, 30, 40 years older, maybe I would think about increasing my follistatin. I mean, right now, like I haven't even had kids yet either. So, and I want to, so I don't want to be really going in there mucking around. Everything I do, especially now, again, I used to do things that were like a little bit more risky, but it's a big risk versus reward versus when's the right time to do it. I am actually kind of excited about this gene therapy for cardiovascular health that just kind of.
I'll say so the PCSK, basically the LP(a).
Yeah.
The one that lowers LP(a). So here's a problem with that. So number one, right now, it's been shown that it dramatically lowers LP(a). Mm-hmm. As far as studies have looked, they've seen no change in cardiovascular events.
In outcomes, yeah.
Right? So is that outcome? So is there something more to LP(a) that we don't quite understand? So just lowering the LP(a) is not the full answer here, right? Is there something more to the story that we don't understand, or is it just a time? We haven't had enough time. They're also showing some small people now incidents of liver damage. So I don't even know if we're quite there yet. That sounds. I was super excited by it too. I've been telling all my patients about it, and now some of the data is coming a little bit more to the forefront. I'm not sure where I stand on it yet. We'll have to see. We'll keep an eye on it.
Yeah. I mean, do you think that cardiovascular disease, this has been, so I have an elevated LP(a). It's about 70. My husband's, we eat the same things. His is 7, less than 7, I think.
It's just
right.
Genetic,
so, and this has been a big battle in my mind for many, many years. And I've had all sorts of different doctors with different opinions. My metabolic health is pristine. The inflammation levels are like nearly zero. What do you think is really driving cardiovascular disease? I mean, but at the same point, it's like I don't want to run a higher LP(a). I'm on Repatha right now. Don't know if I'll be on it forever. Didn't start it until recently. But yeah, it's such a nuanced question about.
So my partner, Dr. Hussein, is a cardiologist, and so we talk a lot about LP(a), and when you truly look at somebody with a high LP(a) who has no other risk factors, they probably don't have they probably have minimal, if any, increased risk of cardiovascular disease. It probably is not an independent risk factor when you actually look at somebody who truly has no inflammatory markers, no oxidative stress, perfect metabolic health like you. When you look at LP(a), it wouldn't have stayed in existence if there wasn't some benefits to it, correct? Yeah. There's no gene that is horrible that stays around forever. Mm-hmm. So when you look at that, we still have a huge number of people who have carried that genetic tendency. Mm-hmm. What are the benefits of it? What we know is it's antibacterial and antiviral. That's why it rises in people after like COVID and things, right? That has some antiviral and antibacterial properties to it. So there is some benefits to LP(a), right? It's not that, it's not that it just exists, some bad gene that's just stayed around with us forever. That doesn't make sense. Genetically, that would go away. So when you look at cardiovascular disease, it's a multifactorial disease. It's mostly inflammatory, and that's why it's pushing down cholesterol. The reason the PCSK inhibitors work like Repatha is they're also, or even low-dose Crestor, for instance, they're potently anti-inflammatory. So if you're saying, well, does LP(a) somehow raise inflammation somehow? In you, it's obviously not, because you don't have any inflammation markers. I don't think there's downsides to taking a PCSK inhibitor unless it's pushing your cholesterol too low. Because what we also know is pushing cholesterol too low has detrimental effects to the brain. Yeah. So, but I do think we need to get a little bit people have gone now way over on this LP little a, like, oh, it's just horrible. Again, it doesn't make sense that something that horrible would still exist.
Yeah.
And when you look ancestrally, there's a reason for it. And it's, and so there's some benefit that those people are carrying. And that's where the problem is, that LP little a becomes a very high risk factor if you're not in a perfect state. And how many people are in a perfect state? Very few. So our goal to lower LP little a is because it's very hard to get everybody in a perfect state. So let's just lower LP little a. That way those unperfect state people are going to be okay. If you look at somebody who's in a perfect state, I don't think your LP little a is creating you a high risk.
Yeah.
That's my opinion.
Yeah. Yeah, no, it's interesting that you say that, because part of a decision factor, and I've already talked about this on the pod, but won't go too deep into it, to start this is, so I got, markers have been like perfect, but then I got E. coli somehow while traveling, caused this gut inflammation, caused leaky gut. Then I saw my MPO increasing. So I also was like, well, if there's any time to take this, it's right now while I'm reoptimizing the gut. And my insulin even rose, it went from like 3 to like 5.5 or something during this. It's incredible how insane the gut
is, right?
Will.
Exactly.
And you just like, I'm sure I picked it up on something like probably like lettuce or something.
Right.
It's like known for being on lettuce, and it's just crazy. But yeah, so I was like, sounds like maybe you agree that maybe my line of thinking here is that if I am going to take it, this would be the time to take it.
Exactly.
Yeah. Okay, good. Right. Well, I'm glad.
Right. Yeah. I mean, my only concern with you is, would it push your cholesterol too low?
Too low. Yeah. Well, I'm going to keep, big tabs on that.
Right.
But yeah, I'm excited for the narrative around cholesterol to change, because obviously it's just like super cut and dry. Like this is how it goes. This is what it is. Like
the functional medicine world's getting all tied into this LP little a, and I think we have to be careful with that as well. It's like, LP little a is super, super important that we keep an eye on those people. And I very much, because most of my patients with high LP little a, I just can't get them perfect. I just can't get everything else perfect.
Yeah.
So I'm anxious for some way to maybe be able to modify that. For now, my goal is to modify everything else and let the LP little a not be a factor. So I don't know. We can keep an eye on this gene therapy. I'm not sure it's going to be the answer.
Yeah. Yeah, it'll be interesting to see what occurs. Do you do clearly scans on your patients?
We do clearly scans on everybody,
Yeah.
Which is, too, also, now I've got a great way to figure out who do I need to be worried about, right? Yeah. If you have a high LP little a and you've got a horrible clearly, then that's somebody I'm going to be a little more worried about, right?
Yeah. Yeah. And
I suspect your clearly is 0.
Yeah, it's great. So that was another reason why I was like, okay, well, we'll wait. And then I really enjoy that too. Other peptides. So we talked about MOTS. We talked about a bunch already. Well, anything else peptide world? Like, do you think GHCKU works well for skin also?
I love it. Yeah. I mean, I think there's so much cool stuff for it. I mean, we'll make a combination of like mix a little GHK copper with a little estriol, and then rapamycin, is amazing for skin too, so you can actually there's so many cool compounds for skin coming out.
I know. Okay. Well, that's another reason why I found a vial that I have in my supplement closet, and it was just the mix of like literally everything. And this I'll also show you the vial, but it was from a compounding pharmacy. And it's like metformin with like all of these other compounds. I'm like, these are all the fun things I used to do. Yeah. Now I'm just living life on the, basic 30 or whatever supplements I take per day. So, and putting in some peptides in there, but I miss all that fun stuff. So, well, I think we covered just about everything. We talked about the joints and we talked about exercise. We did. Anything else from a peptide standpoint that you think people should know, or other peptides that you really, really love?
My handful of peptides I use the most are going to be BPC, Thymosin 1, Alpha 1, Thymosin Beta 4, GHK copper, MODS-C, SS31. I don't think we can not mention that I think personally everybody should be on a low dose GLP-1.
Yes, that's
I think if you look at that from joint health, huge data on it now. What's been shown is that in joints, what that very specific is, we were saying, it's just weight loss that help the joints. Is not. That this is an AMPK activator in chondrocytes. So the GLP-1s actually activate AMPK within the chondrocytes, so they extend life of the chondrocyte basically. So it's very specific that it actually is a really beneficial enhancement to prevent osteoarthritis and maybe even reverse osteoarthritis. In fact, when they looked at people on GLP-1 agonists, they had much slower progression of osteoarthritis. So from an arthritis perspective, definitely, but there is not not one disease that cannot be impacted by a low dose GLP-1, and I do think they're still one of the best longevity agents that tools that we have. Yeah.
When you say low dose, what are you usually referring to?
It's going to vary on the patient, right?
Yeah.
And whether I'm using, I mean, probably everybody will be on retatrutide. Eventually, it'll probably be, that'd be right now. Tirzepatide is probably my biggest go-to.
Mm-hmm.
And you're talking about, usually it's about taking what a therapeutic dose is with them, which means a dose where they're actually experiencing weight loss, experiencing some appetite suppression, and taking that down to about 25% of that dose.
Mm.
So that's typically where you're going to go, is finding a dose that's about 25% of what a therapeutic dose is. Sometimes I'll dose them up to the point where so I know, because it's going to be different in every patient.
Yeah.
So I know, we don't know what a low dose is really, because a low dose is different for you than for me potentially. So I'll dose them up to where, I don't feel like eating, I'm losing a little weight, and then I'll back it down to 50 to 25% of that, depending on what problems I'm treating. I think it's a good rule of thumb, because it's come out with a number that's going to be very different from the size of a person. I have people who, get weight loss on a very tiny dose of a GLP-1, right?
Yeah.
And people have to go to massive doses on GLP-1. So those people are obviously metabolizing it different, utilizing it differently. So that's a way I can figure it out.
Yeah.
Just take them to a dose that's obviously therapeutic. They're losing weight. They don't want to eat, and then bring them down from there.
Yeah. Yeah. Yeah, I was listening to some of the joint research on GLP-1s. I'm like, man, this thing does everything. I mean, do you have any concern, though, like if it's, I don't know, constantly stimulating this in the body, that eventually it'll like just stop responding to it?
So the GLP-1s really don't seem to work that way. They're really not, they're not acting, to cause receptor dysfunction or by stop producing. It just doesn't appear to work that way. So we've seen no change in, when you stop these, the people will not produce their own GLPs. I do think there's a whole group of people who don't produce enough GLPs, right? Genetically, the people with FTO genes don't produce as much GLP-1. So those people probably need an ongoing higher dose just because they have less, or people who have gut dysfunction or who have low Akkermansia levels. Those people have less GLP and probably need a little bit more higher levels ongoing.
Yeah.
It's where this whole it kills me when they say, well, you stop these drugs and you just rebound. Well, people rebound because they actually needed the drug. I mean, they rebound because they had low GLP levels. It'd be like saying, I took you off your blood pressure medicine and now your blood pressure went up, right?
Yeah.
So, the blood pressure medicine was really bad because it kept your blood pressure under control only while you were on it. People who have FTO genes have low levels of GLP-1. People who have different kinds of gut microbiome have low levels of GLP-1. Obviously, they're going to rebound when you stop the drug. You were treating their problem. So that's a stupid argument.
Yeah. Yeah. I mean, but probably the biggest thing there is just making sure that people are working out and getting protein in.
Right.
Yeah.
And hydrating.
Yeah.
We forget hydration. So, one of the things I was just talking to one of my patients, because she'd been noticing blurry vision, and everybody's now scared about the GLP-1s with blurry vision. Very rare to see the optic infarcts that are occurring. Those only occur when you drop blood sugar really fast in people. But the blurry vision is because the eye is really sensitive to hydration. And people are very much dehydrated when they're on GLP-1s. You need more fluid intake, and you need more, lots of times using things that help push fluid into the cells. So like that's something called eye cell water, which is a combination of amino acids that pushes the water into the cells. So we forget how much hydration is important for muscles, and most people on GLP-1s are not drinking enough water.
Yeah. Okay, one of the last questions, I think. What about melanotan peptide? I've been scared of it.
So I love melanotan. I don't take it, guys, because I'm so dark-skinned that if I take it, I have taken it because I actually like the way I feel on it. But it makes me completely black. I mean, I look like.
And are we talking about melanotan 1 or 2?
Melanotan 2.
Okay.
So melanotan is part of the melanocortin system. Melanocortin system has very important functions. So we think about it for getting tan, right? It stimulates melanocytes, but it has really important immune function, really important neurotransmitter function benefits. So they've studied the melanocortin system in depression, in immune dysfunction. So it's really hugely beneficial for people with autoimmune diseases. In fact, it's when we lost melanotan, when we couldn't get it anymore, a lot of my patients with autoimmune diseases really went downhill because it was so helpful to them. So people have dysfunction in the melanocortin system that explains some of their autoimmune disease. This is the cure. It's the treatment for it. I think people get scared of it because they think about, well, I'm stimulating melanocytes, am I going to cause, melanomas? No, you're not going to take a normal melanocyte and turn it into a melanoma. What you might do is if somebody actively has a melanoma, you might make it grow. Now, in my mind, so I have somebody who didn't notice something and now they do, right? So they had cells there. They brought to the forefront, and now you can actually, usually very early, deal with them. So you can biopsy and say, oh, this isn't melanocytes. But probably was there underlying, exposed by the melanocytes. But when melanotan first got discovered and looked at, it was actually looked at treatment for treating people who were high susceptibility to melanomas. So that's actually, it was because it actually if it increased in the melanocortin system, increased melatonin or melanin in your melanocytes, they actually were more protected against skin cancers. I have a friend who's a rock climber. He's a freckled face, redhead rock climber. So he's out in the sun all the time. He literally would get like one little cancer after another on his face. His skin, it was like he sunburnt at the drop of a hat. For him, it was such a godsend to have something that he could actually be out in the sun and not burn constantly. So I think the cancer risk, when people say, oh, it exposed to melanoma, it's probably exposing, not causing a melanoma. And to me, that's a good thing. It's bringing to the forefront something that was there. But the main benefits of it, aside from it does make you increases libido, makes you more tan, helps muscle development. It's really good for the immune system. So, you don't want to be using it continuously. It will increase libido. In some people, a lot. Men more than women. Yeah. But in some people, a lot. So that's, you have to be a little cautious with that aspect of it. And it does help muscle. It helps build lean muscle. So not a lot of downsides to it. Like I said, the biggest downside is you will find anywhere that has a lot of melanin, like freckles, get darker. So if you're a freckly person, your freckles will really show up. And also under your eyes tends to get a little darker for some people. So then cosmetically it can look kind of bad, right? You get more freckly or darker freckles or more dark circles under your eyes. Or if like in somebody like me, you just really literally look stupid. I mean, I look so like weirdly black. It was like, it's a weird color black. It's like I just look way dark. Yeah. Like kind of a weird tint, especially when I'm in the sun at all, because I get tan super fast. I don't burn at all. But it really is a valuable, and when we could just get it back now. We actually just got it back as a peptide to be able to compound. And one of my friends who has a really severe autoimmune disease, it literally was her saving grace. And so that without it, she was much sicker than she is now back on it. Wow,
that's incredible. Thank you for educating me on that. Last one now. I have, what about these libido peptides? And then is there anything that like specifically may be good for women?
So PT141 is the big libido peptide, and it works in some people. It has a very high side effect profile of either causing headaches or nausea, particularly in women more than men. Men seem to tolerate it better than women, although men will get those side effects too. So in at least 50% of people, and I would arguably say more, the increase in libido is superseded by the fact that all you want to do is barf and have a horrible headache. Yeah. So it becomes a drug that doesn't work very well in most women. There are a few. I have a few women who it works great in. But I would say it's like 1 out of every 10 people I try it in. Men a little bit better. It certainly helps with the erection quality in men. And they seem to have better tolerance of it than women. Yeah. So a peptide we used to use a lot, really psyched about, because female libido is hard. It is, I think, one of the hardest things to improve, right? And that's because female libido is very much brain specific. It's very much, if you're stressed, if you're anxious, if you're in pain, if you have anything going on, your brain will turn off any desire to have sex, right? Men not. It doesn't matter what's going on, they want to have sex. So men are easy, women are not so easy. You can optimize their hormones. You can get their testosterone perfect, their estrogen perfect. They still have low libido. The thing that has, for me, helped the most with patients is two things. Number one, oxytocin. So oxytocin nasal spray can be helpful, at least in some women, not in all, but in some women, using oxytocin nasal spray seems to really increase their libido.
I used to do the troches. Do you like those
ones?
Troches
too. Yeah. Troches, either one. Yeah, both fast absorbing.
I needed a lot more hugs in my life back then.
Yeah. So I think the troches and the nasal spray, both great. I even like just using oxytocin nasal spray. Just makes you feel a little happier, a little more social. I'm not a very social person, so if I do a little oxytocin nasal spray, I can interact with people better. So oxytocin is kind of underutilized peptide hormone. Yeah. The only thing I really found helped a lot with a lot of women is something called tesofensine. And tesofensine is actually a drug. It's approved in other countries for weight loss, and it works very well for weight loss. But it's a triple neurotransmitter uptake inhibitor. So basically get an increase in serotonin, norepinephrine, dopamine, and somehow that combination of this perfect triple uptake inhibitor is people really get an increase in sex drive. It's not just dopaminergic, because dopamine seems to on its own not play the role, but it seems to be this perfect balance. So tesofensine has been the one thing where I've seen women actually get really increased libido with. You have to use it on kind of a sustained basis. It has the issue of it can cause weight loss. So, if somebody who's skinny, then that becomes a problem because you will almost always lose weight.
Yeah.
It's a good weight loss adjunct drug. It does. You have to watch blood pressure a little bit because it will increase blood pressure a little bit. But I think we're still there's the Ad-Ye pill, which is that little pink pill that is on the market that works more on neurotransmitters as well. Some women seem to do well with that. But I don't know if we have the perfect peptide yet. I think we still have to keep looking at women libido. I think the biggest thing is that women just carry a lot more stress, and you have to probably working on how do you get them to a place where, even though the kids are all over the place and they have jobs and they have dishes to do and they have all these things going on, how do you get them so they can turn that off? Because that's a difficult thing to do.
Yeah. Do you see success with the deep sleep inducing peptide?
The DSIP gets a lot of hype, and I'd love to say it works great. It works in a few people well, but it's not so great. Rarely do I have my insomniacs. I can put them on DSIP, deep sleep inducing peptide. In theory, that's what's produced like in mother's milk, and that's why babies nurse and fall asleep, and and all these great things about it. It is helpful sometimes for resetting circadian rhythm, and people, I'll find it useful there. And there are a few people where they do seem to respond well to it. But it's another one of those peptides where, it's years and years and years of using it. I've used it less because I've just, it's one of those things where we can try it, but my likelihood of success with it is probably going to be in the 20% range.
Yeah, we kind of saw the same thing too. I was just wondering if it improved at all.
Yeah, I wish there was something that really helped that, because sleep is also another one of those things that's really a struggle with people who can't sleep.
Yeah, I agree. I mean, the only thing that I sleep really well. I'm very blessed to have that. But I mean, I really do like the cooling devices for the bed.
Yeah.
I mean, I see good improvements in deep
improvements.
sleep. So, yeah. Well, it's been such a pleasure to have you on the podcast today.
Thank you, Kayla.
Yeah, where can people find you?
So basically, our clinic is Boulder Longevity Institute in Boulder, Colorado. And if you go to www.boulderlongevity.com and just fill out a new client little thing, somebody will call you and contact you. Follow me at Dr. Yurth, or on YouTube, Dr. Yurth, and Facebook. And then we also have an education, so we have a sort of academy. So bli.academy, where we have training sessions where people can sign up, and we do these amazing Q&As every month. I mean, this program was actually designed for just regular people, but now it's like mostly physicians and practitioners, but everybody's invited. We do these great Q&A sessions every month that people ask me the hardest questions that are really fun to go through. So we talk about peptides and hormones and everything in the month. So bli.academy, it's inexpensive to join that, and we give a lot of information for that. So and just keep checking back, and we'll keep adding more information to that as well. Thank you, Kayla. I so much appreciate you. And that was a lot in a conversation.
It was, but it was so fun. I mean, I could have done this all day, but you have a flight, and I have a book. But the last question I was going to ask. So do you only have to go to your clinic in Boulder to be seen, or do you have a
I'm
license?
licensed in pretty much every state, 48 of the 50 states. So we see a lot of our patients virtually.
Amazing.
So most of our patients, we can do everything virtually. Obviously, if you want a procedure done, people fly in, but a lot of times they'll fly in for, a few days and then leave. But we see most of our patients virtually. Most of the things we can do virtually. We have patients really all over the world.
Incredible. Well, we'll make sure to include all of that in the show notes. And thank you again for coming on.
Thank you.